my presentation is concluded. Shall I stop sharing the screen?
Kanila.
Hello.
Hello, ma'am.
Yes.
Can you hear me, ma'am?
Yeah, now I can. Yes.
Okay. There were some technical issues, ma'am. Okay, ma'am. Thank you, ma'am, for your remarkable session, and which was excellent, and it was beautifully loaded with the content loaded slides. And thank you for your participation, ma'am. And I take this opportunity to extend our sincere gratitude to Wahida, ma'am, for spending her valuable time with us. Thank you, ma'am. Any queries from the audience? Okay. Okay, ma'am.
Yes.
So now, I think there is no queries from the audience, ma'am.
Sure.
Thank you.
Thank you. Thank you so much.
Thank you, ma'am. Now we request all of you to refresh yourself with a 15 minutes break. Please stay online and just join us back at 10:45 a.m. without fail. Thank you. You can take 10 minutes break. Audience, please stay online and you can join us back after 10 minutes. Hello.
Dr. Sharbas ഒന്നോ സച്ചിൻ ഇവിടെ ഉണ്ടല്ലോ. Okay, hello, Dr. Sharbas. After a long time. Vivian.
Hi.
Hello, ma'am.
Sachin is here.
Yeah. Good morning, ma'am. Samir.
Good morning, ma'am.
Good morning. Zamir also has come. Okay.
Yeah.
Good morning, ma'am.
Dr. Sharbas, Assalamu alaikum.
Walaikum salam.
How are you, sir?
Good.
Good.
Nice to meet you all again.
Meeting everyone after a long time, even though you're...
Hello, salam alaikum to everybody.
Walaikum salam.
Walaikum salam, ma'am.
Hello, Sharbas. Sharbas,
Ah,
assalamu alaikum.
Raman.
How are you?
Raman, sir.
Oh,
Assalamu
alhamdulillah,
alaikum, sir.
sir. Oh, Sir Samir. Oh, beautiful.
Yes, sir.
Yeah, he looks very handsome now.
Wow.
He was also always handsome.
നീ കുഴപ്പമൊന്നുമില്ല, നീ ഭയങ്കര ഭംഗിയാണ്.
Looking handsome.
ആദ്യം
Young also.
പറഞ്ഞിട്ട് പറയാൻ വേണ്ടിട്ട് നിന്നതാ സാറ്.
Vivian, Samir, Dr.
mashallah.
Sachin, Dr. Sharbas, all are looking very, very handsome.
Great. Thank you.
So how we will go live now, or we waiting to go live, or how is it, or it's already on live? How do we
Yeah.
start?
Okay, starting.
Ma'am, shall we start now?
We're going on
Once
live.
again, welcome back, everyone. We appreciate you for being with us. Let's now move on to the interesting part of today's conference, the panel discussion. The topic is strategies for quality assurance in healthcare management. In our panel, we have 5 experts from the field of management. The moderator for the panel discussion is our respected principal, Dr. Asma BVTM, Director, Aster MIMS Academy. Madam is a brilliant teacher and an outstanding administrator who has devoted her time and energy not just for developing nursing as a profession, but also to widen the knowledge base of nursing through critical thinking, and often she strives to uphold the quality in healthcare management. She was awarded with doctorate in pediatric nursing by the University of Calicut and holds a diploma in medical education and various other merit certifications. Dr. Asma BVTM is one of the approved guides of National Consortium for PhD in Nursing by Indian Nursing Council and is the Vice President of Nursing Research Society of India. Madam has worked as a senior teacher at Ministry of Health, Oman, and also is an Assistant Dean, Academic Affairs, College of Nursing, Sultan Qaboos University. Madam has authored many books and so has several publications both at national and international levels. It's now my pleasure to call upon Dr. Asma BVTM. Over to you, ma'am.
Thank you, Sri Lashmi. We have a panel. Yeah, today's topic for panel is strategies for quality assurance in healthcare management. And we have tried to get the best possible people, the 5 experts, actually 4 experts, Dr. Sachin Suresh, Dr. Sharbas Bichu, Mr. Samir PT, and Mr. Vivin George. First, we will be the first panelist is Dr. Sachin Suresh. I would like to introduce Sachin to all of you. Dr. Sachin and Suresh has completed his BAMS Ayurveda degree from Ramakrishna Ayurveda Medical College, Bangalore. And he did his master's in hospital administration from Kasturba Medical College, Manipal. Actually, he was, his career was started with us in Ashram MIMS Calicut as assistant manager operations, and he worked there for 3 years. Then he attended, during this time itself, we know that how efficient he is, and Ashram MIMS used to regard him as one of the best in our industry. And he has attended and organized various conferences and also has done number of projects in the field of administration. Presently, presently he is in Sultanate of Oman, but before joining Sultanate of Oman, he was a manager operations at Indiana Hospital and Heart Institute, Bangalore. He will be talking about lean management. It's a very important area as far as quality is concerned, especially in cost containment. I invite Sachin to deliver his talk.
Thank you, ma'am. Thank you, Asma, ma'am. Good morning to all. Hoping everybody is safe and doing good. So myself, Dr. Sachin, I'm sharing my screen here now. Okay, about my organization, I'm currently working in Badral Sama Hospital. It's one of the most trusted brand in Oman. This is a 20-year-old organization with both JCI as well as ACHS accreditation. And we are having overall 13 branches all over Oman. And I am heading the customer care as well as patient excellence department at Badral Sama Hospitals.
Hello,
So-
Sachin, will you be able to put it in slide share?
Sure, ma'am. Sure, done, ma'am. Okay. Okay, ma'am. Let's begin the topic. So I'll be talking here about the lean management system in healthcare. Okay. So as you all know, lean management, this is a principle started by a car manufacturing company called as Toyota to improve the quality of the services. So talking about lean is a set of operating philosophies and methods that can create maximum value for patients by reducing waste and wastes. So based on the Toyota model, it focuses on how efficiently resources are being used and asks what value is being added to the customers in every process. So the two important points which we have to note when we are starting to learn about lean is first is waste and second is value. So value means the one which adds the inputs to the customers, or the one which enhances customer satisfaction is called as a value, and one which does not is called as a waste. So lean management is purely focusing on these two aspects, that is waste as well as value. So it shows how much efficiently we can add value to the customers. Okay. Second point is lean healthcare is the application of lean ideas in healthcare facilities to minimize waste in every process, then procedures and tasks through an ongoing system of improvement. Using lean principle, all the members of the organizations from clinicians, operations and administration staff continually strive to identify area of waste and eliminate anything that does not add value to the patients. Okay, so according to Taichi Ohno, one of the founder of Toyota, there are mainly 7 wastes in the industry. Later, Toyota added one more waste, that is the 8th waste. So, telling about the main wastes in the healthcare industry. First one, as we all know, it is the waiting time. So, this is one of the major wastes which leads on to the patient dissatisfaction. That is the waiting time for the consultation, investigations, etc. Second one is the inventory management. Inventory management is nothing other than the stock. How much stock we are maintaining, that is also a waste in an organization. So ideally, we have to maintain a proper stock so that the cost will be reduced. So this is usually helpful for the management professionals. Third is like defects, the errors, and the other thing which happens in an organization is the third waste, that is the defect. Fourth one is nothing other than the transportation. Transportation means it is nothing other than moving patients unnecessary from one area to another. It can cause medical errors, severe injuries to the patients, etc. So what is meant by transportation is like we have to organize things in such a way which is easily accessible for the patients. Fifth one is the untapped human potential. Untapped human potential means it is the misutilization of the human resources. So every person, every human resource in an organization has to be utilized in such a way that the wastes that can be reduced. Sixth one is the over processing. Over processing means it is nothing other than the duplication of the work. Doing the same thing which we are doing again, that is called as over processing. And overproduction is mainly, if I can say an example, it is mainly the average length of stay of the patient. Unnecessarily, if patients are staying in the hospital, it's actually a loss for the hospital when we are counting about the profit and loss. Then motion is nothing other than the hospital workers, which they move from one place to another, that does not constitute any value to the process. That is called as motion. So there are usually 8 wastes in the healthcare as per the lean management principle. So overall briefing about lean. Lean is a set of philosophies. It usually works on 2 points. First is value, second is waste. The main aim of lean is to reduce the waste and to improve the value so that it leads on to the customer satisfaction. So in order to apply lean, we have to use some tools. There are many tools which is usually described in the industry. As the lean started with a manufacturing industry, because it is concentrating more on the quality of services, healthcare industry adopted this principle. So there are many principles, many tools that a lean can be implemented. The majority of the 5 tools will be discussing here. The first tool which we usually use in implementing the lean principle is the DMAIC. That is define, measure, analyze, improve, and control. As you can see in the picture, 5 processes are there. First thing what we have to do while applying this tool is first we have to understand a problem and we have to define it. Okay, define in the sense like what is that particular problem about. So we have to define that particular problem, then we have to measure it. Okay, how much that problem is creating impact in the particular process of the hospital or the day-to-day operations of the hospital, that have to be measured. Then an analysis has to be done. So for doing analysis, different tools we can use like root cause analysis, Ishikawa fishbone analysis, different types of tools are there in the healthcare to analyze a problem. So once this analysis is done, we'll be able to find out the waste. What are the waste which has to be eliminated from this particular problem? So after eliminating all these wastes, an improved process is created. So that is the fourth step that is called as improve. And fifth one is the most important step is the maintenance. Once an improved process is created, maintaining that process is the major challenge. And that is the major step which we can define in this particular process. So the first tool is DMAIC, define a problem, measure that particular problem, analyze that particular problem, exclude all the wastes from that particular problem, create an improved process, and last one is maintain that particular process. So that is about DMAIC. Moving on to the next tool which we use in lean management is the 5S in healthcare. As you all know, 5S in healthcare, it stands for sort, shine, set in order, standardize, sustain, or self-discipline. It represents a set of concepts that helps organizations to ensure a clean and organized workplace and aims to improve the work environment, reduce time that does not add value, increase productivity, improve quality, and maintain a clean and organized work environment for the new changes. So if you're telling, if you're considering a common example, while cleaning our house, the first thing which we usually do is like we sort items. What are the commonly used items? What are the less commonly used items? So like that, we'll do a sorting. So that is the first step which we usually use here. That is sorting of the problems or sorting of the steps that we have to concentrate more on. Okay. Then next one we'll do is like we'll do a shining process. That is all the damaged items or the items which has to be repaired, everything we'll take it up. Okay. When we'll remove it and we'll make a proper sorted items. Okay. So that is called shining process. Third one is set in order. Set in order means all the items which we sorted out, they are arranged in a sequence of process that relates to the work. So sequential arrangement of the process is called as set in order. Fourth step is standardize. Standardize means it is making different areas with the same function, it looks the same. That is standardizing policies and other aspects in order to prevent the duplication, as well as if any unwanted changes are there in that particular areas, while after doing this standardization, we can easily identify it. So that is the fourth process, that is standardized. Okay, last one, it is the same process, that is sustain. That all the things which we have done, it has to be maintained properly so that the errors will not happen in future. So this is about 5S in healthcare, that is sort, shine, set in order, standardize, and sustain. So this is the second tool which is commonly used in the lean management principle in the healthcare sector. Moving on to the third one, that is the rapid process improvement workshop. So rapid process improvement workshop, how it is a different tool because it is a team-based approach. So it is a workshop which usually conducted for a week, maybe 7 days, where the team of patients and their families, staff, and clinicians, they focus on one problem. Identify the root cause for it, create solution, and implement the solution in the workplace. So how this is done, what are the main things which we have to focus on while doing RPIW is, first is prior to the discussion, we have to do a proper data collection. That is, what is that particular problem? What is the current scenario? So that we have to do prior to the discussion. And on the day of the discussion, with all the stakeholders, we have to do a data analysis and a process mapping and a factor identification. So once these three processes done, that is data analysis, process mapping, and factor identification, an action plan is usually set for the future practice, and this has to be maintained. So RPIW, Rapid Process Improvement Workshop, it's a collective team effort where all the stakeholders are involved in the brainstorming, and a particular decision is made, and this is usually maintained. So that is about the fourth tool, that is RPIW. Coming on to the most common tool which we used in the lean management principle is the value stream map. So value stream mapping method, it includes the visualization of the complex workflows, the quantification of the resource needed, and restructuring of the workflows into an improved version which focus on the patient needs. Okay, so if we can explain it in a simple sense, it's like once a patient comes to the hospital, till the patient leaves the hospital, what all are the different activities involved in the patient activity. So based on that, it is divided. Step-by-step division is usually done. It is evaluated, and a new process is created after eliminating all the wastes. So there are usually 6 phases for value stream mapping. For in first phase, what we usually do is like a current state value stream map of a process is developed. Like what is happening in the current situation, that process is usually developed first. In the second phase, it follows with identifying wastes. As we all know, the second phase, it is mainly the identification of the wastes. Okay, first we'll be doing a proper process mapping, what is happening in the current scenario, then step-by-step evaluation will be done. Based on that step-by-step evaluation, all the wastes which we understood it is usually taken out. And in the third phase, the solution approaches for the improvement of the process are developed, and it is usually converted to the future state value stream map. So what all after eliminating all the wastes, that remaining item, that the remaining refined process, it is usually set as a future state value stream map. This happens in the third phase. In the fourth phase, this is being converted into say future value stream map is usually converted there. And in the fifth and sixth phase, the implementation happens. So this is the most effective and the common use tool in the lean management in healthcare, that is value stream mapping. It's a visualization from each step-by-step evaluation of the process is done. Then wastes is usually identified from that process, eliminated, and then a future stream is set. And after that, it is implemented and a control mechanism is maintained. So it is about value stream mapping. So there are mainly 5 tools which we usually commonly use in the lean management. First is DMAIC. Second is 5S in healthcare. Third one, rapid process improvement workshop. Fourth one is value stream mapping. And fifth one, it is nothing other than Ishikawa diagrams, or called as fishbone analysis. This is a tool which we usually use for the root cause analysis of a particular problem. How it is effective in lean management is like the first stage of lean, that is identification of the waste, is for the identification of the waste, this tool can be usually used. As you can see, fishbone diagram, it is a visualization tool for categorizing the potential causes of a problem. This tool is used in order to identify a problem's root causes. By doing a step-by-step evaluation of a problem and by brainstorming, the areas which will not contribute value to a customer, it can be identified and eliminated. As you can see in the diagram, on the right-hand side, as a fish head, you can see the problem. Okay, so as the fish bones and branches, you can see different areas which we have to concentrate to identify that particular problem. For example, it may be equipment, it may be process, people, materials, environment, and management. Okay, so from these particular areas, we'll identify that particular problem. Then as here we can see the ribs of that particular fish. Here we have to note down the cost. For example, if it is a problem related to an equipment, so what is the cost for that? Okay, what is the cost which caused that problem? So based on that, we'll identify step by step and we'll do a proper root cause analysis. So Ishikawa diagram for a lean technique, it usually helps in identifying the problems by doing a root cause analysis of a particular problem. Okay, so after doing all these things in the lean management, so the basic concept is like the elimination of the waste. Okay, so what result we can achieve from this? 3 areas are there mainly. First is like the health system improvement outcomes. The second one is the patient outcomes. Third one is the professional outcomes. Health system improvement outcomes means it is like the common thing, that is the admission time, collection time, turnaround time, triage time, time to see a physician, dispensing time, length of stay, which is commonly related to the hospital operations. All the things which is related to the hospital operations comes under health system improvement. Second one is the patient outcome. What patient achieves from this, that is patient satisfaction, mortality rate, readmission rate, etc. And professional outcomes like employee satisfaction, time spent with the patient, staff overtime, etc. So by using lean management principle, if it is used in a proper way, the wastage which is there in the hospital operation can be identified easily, it can be eliminated, and we can set a new process, and we can achieve all these outcomes. All these outcomes. Okay. Thank you. Thank you, everyone.
Okay, thank you, Sachin. It was a wonderful presentation. And now I'll call upon Mr. Vivin George. Vivin George is a healthcare executive with 8 years of experience running various facets of hospitals. After his post-graduation from Tata Institute of Social Sciences, Mumbai, he joined the flagship hospital of Astra DM Healthcare Group, that is Medcity in Kochi. Then he has transferred to Astra Medical College, Wayanad, and now he is working in as Assistant General Manager Operations in Astra MIMS, Kannur. Over to you, Vivin. He is very passionate about Lean Sigma, and he will be talking on Lean Sigma. Over to you, Mr. Vivin.
Thank you, ma'am. Thank you so much for this wonderful introduction. It's always a pleasure to be speaking with all young and enlightened minds. First of all, I should commend the MIMS Academy and the MIMS College of Nursing for having put together this conference, even amid this COVID situation and the difficulties thereof. Because organizing anything is difficult at this time, and organizing a conference is even more difficult. So great job at that. I'll just first share my presentation.
So are you able to share the screen?
Not yet. 1 second. There is
Okay,
some
sir.
issue.
Take your time, sir. Okay.
Okay. Okay. Has my presentation come up now?
No, sir, not yet.
Not yet. Okay. Just give me 2 minutes. I think there is some issue here.
Okay, sir.
There is some issue with my system. I'll just log in from another system. If the next speaker would like to go ahead, I'll just get this thing in order by that time.
Okay, sir.
Okay, so can I ask Mr. Samir to continue with it?
Yes, ma'am, please.
Yeah. Can I introduce Samir then? Okay. Mr. Samir is a seasoned top-level executive with 15 years of experience in corporate hospital operations and business development, nationally and internationally, accredited leading corporate hospitals and in India as well as in the Middle East. He is a graduate in chemistry and also obtained two postgraduate degrees in information technology and business administration. He started his career as an executive in the Department of Relations at MIMS Hospital, Calicut in 2005. Through his dedicated service and hard work, he reached the position of deputy manager within a span of 4 years. In 2013, he moved to KIMS Hospital, Trivandrum as a business development manager. He worked as a chief operating officer at Indiana Hospital and Heart Institute, Bangalore from 2014 to 19. And in 2019, he joined back to MIMS as Chief Operating Officer. And in 2020, he moved to Badr al-Sama Group of Institutions and Sultanate of Oman as Chief Executive Officer of Badr al-Sama Group of Hospitals and Polyclinics, Muscat. Over to you, Samir.
Good morning, everybody. Thank you so much, Asma Baby Madam, for this invitation. I would like to thank Managing Director, Engineer Rahman sir also. It is basically a home for me. I started my career, as it is mentioned in the introduction, started my career in MIMS, and it is always happy to associate with MIMS and MIMS Academy programs. So I would like to share my screen. Is this visible?
Yes, yes.
Yeah. So I would like to talk about quality circle. Quality circle is a very simple concept, which is very prominent, and it is followed everywhere. It may be followed in your organizations also. But this has got a peculiarity where it is something different for addressing a problem what is faced in your organization. So this can be applicable in any industry, not only healthcare, any industry, in automobiles or in the construction areas or in the hospitals or service industries. So the definition of quality circle is basically it's a small group of employees. They volunteer to come together for a reason to improve and involve in this problem and improve that, recommendation, give the recommendations and improve the total effectiveness of the problems, whatever it is circulated. So every program, every organization or every institution will have issues on daily basis or on this productivity, or on the safety issues or on the quality issues, efficiency matters, then revenue leak, all these kind of issues will be faced on daily basis. So this is a systematic approach where a task force will be formed to tackle that problem with the authority. So once we are addressing that problem very systematically, then it will be easy for us. So let us go through that. How are we going to do this quality circle? So these are the basic quality circles, objectives what we developed. So first one is that by introducing this quality circle, it will be easy for us to develop a system where all members are participating in it. It is for a participative culture that will be generated. And team spirit also we can introduce, or a team spirit also we can maintain in this organization. Then second one is that we can, by introducing this quality circle, we can ensure that there is an increased productivity. So what we are doing this quality circle is that we are addressing a problem. And once we are addressing the issue, definitely that will be converted into a productivity increase. Then in the case of hospitals, definitely we can ensure a better patient experience or a customer experience, and prevention of the revenue leakages, what is happening in organizations, can be tackled by introducing a quality circle. These are the few, objectives of the quality circle. Basically, this quality circle is for a specific task which can be addressed in a very easy way. So once you come to Bhadrasama is already accredited by JCA and ACHSI. So, but this quality circle will not be restricted only to the quality department or quality accreditations. See, one main thing what we wanted to mention once we are forming a quality circle. So, quality circle, how are we forming it? So, let us start about the steps of the how to form a quality circle. First one is that we have to identify a problem. So, once we identify a problem, we may have to sum up, or we have to team up for this task, and we may have to form a steering committee. So steering committee is nothing but the authority will be with the steering committee, and this steering committee will be the responsible for introducing this quality circle and also for monitoring also. So there will be the apex team which is formed for tackling that identified problem in the organization. So next we have to identify a facilitator from the senior level. So that facilitator will be the person who is coordinating the steering committee, and also he should be the person coordinating all the members who are working in this quality circle. So then next we have to do that, define a workflow and objective. So we have to define. So once the problem is there, what is the objective of this task? What are we expected out of this quality circle at the end of the task? So that objective, what is the outcome, what we are expecting, should be defined in the initial stages. Then accordingly, we have to prepare the workflow for this. Then next, we have to do a training for all the members. And all the members who are going to deal with this problem will be given a basic training. Then we have to monitor this, activities of the committee or activities of the quality circle on a daily basis or a routine basis. And we have to recommend this to the senior steering committee. So once you're looking at the characteristics of a quality circle, so it should be basically, it should not be a compulsory thing, or it should be a very official thing. Usually all organizations go for something kind of an informal kind of circle, informal kind of, gathering will be, introduced for the quality circle. Then these persons, whoever is working in that one, should be comfortable with whatever the assignments or whatever the problem they have taken up. So in a hospital and all, if you are going for a problem, if it is something connected to a revenue, if it is something connected to cost, all these things, we will keep one person from finance, one person from inventory, one person from the billing, all these kind of. If it is something clinical, so we may have to select the team members accordingly. Respective experts should be taken from that respective area. So another characteristic, it should be, as I explained earlier, it should be a very participative, and also the objectives should be very clear. So once the objective is clear to all persons and whoever is there, they will have only one motive. So that is another characteristics or effectiveness of an effective quality circle will be formed. So then another thing is that listen to each other. So we have to listen each other for this developments, suggestions, whatever the observations we are receiving. Then usually this quality circle characteristics or effectiveness will be at the peak once you are coming to a kind consensus, not like a voting or a fighting, all these kind of things. So next, let us think about a few recommendations for a few initiatives which we are in our hospital. Also, we have introduced a few quality circles. So we know that it is possible in every organization. You can come up with according to the nature, according to the issue what you are facing. So usually quality department is considered to be the responsible for ensuring the quality in the department. So the quality department, if they are coming into the picture, everybody will depend on them, and they feel, all the employees or all the stakeholders will feel that the quality should be introduced by the quality department, and it is going to be their responsibility. So once we are coming into this kind of stage, we have to break that a notion, and we have to give an equal responsibility for each and every staff, whoever is working in that organization. So we also here in Bhadrasama also we follow this one. So we don't have a very, even if it is a group of 13 hospitals, we don't have a person who is exclusively marked as a quality, head or a quality person. But we have identified a coordinators from each unit, and we give them the responsibilities according to the task or according to the assignments we wanted to take it up. So another thing which we wanted to, tell you that few initiatives, what I wanted to, one is a proactive informers group. So this is the one method which we have identified in our organization very well. So there are many these kind of, groups are there in other organizations also. In Aster, when we were in Calicut and Dubai and all, we have seen that whistleblower. So what we are doing is that we will identify a persons in each area or in each organization. When it is a big organization or a network of group, so even if it is a departments, we will identify persons for a proactive informers group. So this is nothing but the person, whenever he is getting a signal or whenever he is getting a feedback from the services or from the patients or from the market, he has to develop or he has to communicate this to the top level. He has to blow his whistle saying that, okay, there is a tentative problem which is going to happen. So once he is identifying this one, and he'll be given a responsibility or he'll be free to communicate this. So his work will be only that person. So he can just inform this the group saying that there is a potential threat. So these kind of threats, whenever it is identified, so it may be, see, usually quality department also will come in the picture whenever there is an issue, whenever something has happened, then quality department will come. But this proactive informers group is nothing but they will be proactive and they'll be capturing this data or getting the information from the market or from the group or from the departments and put it in advance. So they can suspect, they can warn, or they can inform the leader saying that, okay, there is a potential threat, what is happening. So once we are moving into that, then it will be easy to tackle this. So this can be one of the quality circles which you can introduce in your organizations also. So another thing what we are following in our organization is that a dynamic deployment of nurses. See, every time we face problems, especially in Middle East and all, it is not easy to recruit the nurses from all the areas. So border issues, then COVID was the one issue, then visa restrictions, localization. There are different challenges what we are facing. So in that case, so what we did is that in the on 13 branches, we identified a persons for identifying a deployment of a nurses in a dynamic way. It should not be a fixed. It should not be a fixed duty roster for the month. It is going to be duty roster or duty schedules will be fixed according to the each shift. There will be a person. So each person, each area, this is a very common practice which is happening in other hospitals also. It is acuity based nurse, deployment. So this is something like that where whenever the number of patients are up more, so from the pool also the nurses will come and take up this challenge. And this team itself formed by nurses, they themselves will form a team and they will alert or they will prepare this as a chart which we are following in our organization. And they will ensure that according to the number of patients available there, they will ensure there will not be any excess or shortage in that area. So this is the one task force or a quality circle which we are following in our organization. So this is very effectively managed during the peak COVID time. So as it is different units in different places, we were not in a position to identify whenever the patient load is increasing one area, the other unit will support this the other one. Where the crisis is there. So as per the locality, as per this infections rate and all, this was introduced very well. This is another quality circle which we have formed in our group. It is nothing but every day there will be a good number of patients will be visiting the branches or all the hospitals. And whenever the patients are coming in on board, there will be some issues for the patients. They will have some suggestions or they will have some feedback which they wanted to share. We got a system we call it is a Sampia system. It is an online based system. You can just go scan the QR code, then you can give the report. So immediately once the ticket is generated, it will be sent to the person's hierarchy wise, and this has to be addressed in that specific timing. So whenever this quality group or a quality circle, this group of team, they get a feedback, or if it is generated in anywhere in the branches, immediately they have to take it up. They have to reach the patient immediately. There is no time. We are not even giving 24 hours. We are telling them before you leave the hospital or before you leave the the duty time from the hospital, we have to address. So without this one, and also there will be this quality group, this circle will be meeting on everyday basis from all the branches, and we will discuss what are the issues they find, and this will be sorted then and there itself. See, another thing is that another quality circle which we can introduce in a hospital is that, see, from the nurses itself, rather than, see, usually nurses will be doing only this clinical works, and they'll be taking care of the patients. But in our hospitals, what we suggested, or one circle or a group, what we prepared is that we would request to team to form a team. They will have a better communication with the patient. They will have a kind of auditing will be done on daily basis. So we identified a person, that person will be taking a lead, and they will have a discussion with all the departments. And if it is a supporting departments also, they will discuss and clarify then and there itself. So all these kind of assignments which is given to the team, so they take it up, and which has helped us a lot for the prevention of the revenue leak and billing of service. If there is any billing, it is not. That was the main problem what we are facing. Many of in every organization it will be there. So patients, services may be given, but it may not be billed. So consumables sharing, consumables comparison, usage of consumables, that also will be taken up. So these are the a few initiatives which we are following in our organization. And there are n number of issues or n number of quality circles which we can form in each organization according to the nature of problem what you are identifying. And what are the challenges for this one? So first and foremost thing is that we have to get a permission from senior management saying that these kind of groups are formed in organization to take up the challenges. So what we do is that whenever we form a team for taking care of the task, so the task will be defined, and what is the problem we are identified in the organization, and what is the outcome, what is the expected outcome of this committee or a quality circle also will be defined, and it will be intimated to the top level officials also in the organization, so that they will also be aware. Since in that case, manpower deployment or usage of the persons or the staffs will be dedicated for this one. They may be doing something else other than the routine work they are supposed to do in the organization. Another one objection, task or a challenge, what will be there? See, always there will be departments or there will be responsible experts in that department. So whenever a team of persons, say informal or a volunteers are coming and forming, and if they are coming and interacting with the departments, whatever it is in existence, they will have an objection. They will not be cooperative of this one. So that is the one another challenge which we are also observing. Then whenever the problem identified, whenever the suggestions are recommended by this quality circle or this group of team, if they are not ensuring a flexibility in the allocation of the resources will be another challenge what we are facing. So here also what we have to do is that we have to discuss. See, all these kind of issues can be sorted or fixed if you are coming up with a proper objective for the quality circle, and if it is communicated to all kind of stakeholders. If it is a department HOD or if it is an institution head, whoever it is, once we are announcing this one in advance, then it will be easy to tide over this challenge. Then lack of volunteers. So usually we prefer the person we would suggest. We will not push anybody to drop the work over there and come and join. It is most of the time we would request all the persons to come and join as a volunteers. So into this program. So basically, as a conclusion, what I wanted to suggest is that whenever this can be introduced, even in families also, that is what I feel. So quality circles can be created among the family. Families also will have in society, we can have in a community, we can have these quality circles. Everywhere this is possible. So this is a very good concept which was evolved. It is basically started in Japan many years back. It is in 1850 and itself they started doing these kind of quality circles. So now it is adopted in all the healthcare institutions and many other service industries also. It is adopted, and it is giving a complete outlook, a different outlook to the problems and the problem solving issues. So otherwise what will happen is that there is a conventional method of handling the problems in the organization. So by introducing these kind of things, we will have some kind of informal. Even for the staff welfare issues can be taken into this one. Safety issues, see, sometimes the safety issues will be handled, safety issues will be identified in the organizations. So any problem can be considered for this one. The success of this quality circle is nothing but this has to be discussed in detail. Objectives should be very clear. And once we are introducing this to the team, it should be clear to everybody, and expected outcome also should be defined in advance. So this is a small brief about the quality circle. If there is any other questions, we can discuss. Thank you so much.
Thank you, Samir. Now we will go back to Dr. Sharbas. Dr. Sharbas, you are available now. Hello. Hello, Dr. Sharbas.
Yes. I was in a different screen.
Dr. Sharbas Bichu, I would like to welcome him for the panel. And he is the Chief Executive Officer and Specialist in Anesthesia, Astra Hospitals and Clinics UAE. Sharbas has been a core member of the founding team at Astra.
YouTube live YouTube
Somebody is knocking, please mute yourself.
15th batch
Hello. Please mute Principal MIMS College of Nursing, COAHS. Please mute. Allied Health Science. Okay, we will continue with Dr. Sharbas. Dr. Sharbas Bichu has been a core member of the founding team at Astra Hospitals, and he lives with the philosophy, leadership is the way of doing things. Inducted to Astra Group as consultant anesthetist in 2010 from Astra MIMS Kerala, Dr. Sharbas became the CEO of the first of the Astra Hospitals in Dubai in 2015. His ideas and strategies have created exponential growth for Astra Hospitals in UAE within a brief span of time. Since his appointment as CEO, Astra Hospital has rose to be one of the most trusted healthcare providers in UAE, with 5 operational hospitals under its wing, employing more than 1,300 people, and one more have to be launched soon. Dr. Sharbas Bichu has always been believed in prioritizing the patient and patient needs over the profit, and which is reflected in the improvement of patient experience. Dr. Sharbas, as a primary catalyst, several innovations have been implemented in the past year for the patient's benefit. As a specialist in anesthesia, he has managed anesthetic cases in many specialty surgeries as well as in general surgery. Even in pediatric surgery, he was assisting with anesthesia, and he was managing anesthesia for pediatric surgery clients. He has also managed intensive care of the post-operative patients, head injury patients, polytrauma patients. Dr. Sharbas has completed his MBBS from JSS Medical College, Mysore, India, and MD Anesthesia from JJM Medical College, Davangere, India. He also holds an MHTD from Harvard University. Over to you, Dr. Sharbas. And he will be talking about root cause analysis.
So thank you for the wonderful introduction. And my slides will be managed by Mr. Vijay. Vijay, can you put on the first slide? So thank you, everyone. Thank you for having me for this. And Dr. Asuma, I know her from my yesteryears in MIMS, and her passion for learning, leading, and teaching is always really commendable. So Vijay, can you please put on the slide? So till the slide is on, let me put 2 disclaimers. Number one, I'm not an expert in RCA, but what I have in my wallet is a rich experience, which I've gained over the last 10 years, right from anesthesia to the position where I am now, managing 78 clinics and 7 hospitals in GCC. So are you not able to put my slide? If not, I can go on. So my PPT.
Sorry, sir. Can I request the host to allow the screen share, please? This is Sarah Elias. I'll be sharing his presentation. If you can allow me to share the screen, please.
Yeah. But I'll continue because my slides does not have much of a meat. So more is on not the theory part of it. As I said, I'm not an expert in theory classes. So even if you look at my PPT, you'll see less of theory and more of case scenarios, which will really excite all of you because you're the guys who are going to be in the floor in next few years. And I'm sure some of you are already practicing. Now, when you look at what I hear mostly in this forum is about quality. Now, one thing which I really want to tell about quality is everybody's responsible. It's a responsibility in our healthcare sector. Right from the guy who's standing and welcoming in the floor to the person who's operating in the OR. It is everybody's responsibility. And for quality, there is no finish line. So it's an never-ending process. So you need to have continuous improvement, continuous process. Even if you put process in place, you need to start monitoring, and then you need to see how can I improve this process much further. So there is no end line for quality. With that, can you go to the main slide of mine? Next slide. So I would like to start with a small wording from Kipling. He says, "I keep 6 honest serving men. They taught me all I knew. Their names are what and where and when and how and why and who." So one of the real blessing of Almighty to the entire mankind is the ability to question our status quo. If the status quo was not questioned by our previous people, right, by earlier generation, we would not be enjoying what we have it now. What if Newton did not think why the apple is falling down? What if the Wright brothers didn't think how can we fly? Or if Gandhiji didn't think of how and what strategy should I put to give independence to India? So it is these questions of our ancestors where we are riding on and we are enjoying on. So this status quo, you need to question your status quo everywhere, in your personal life, in your professional life, in your community life, even with your patient. You should always question, why am I doing what I'm doing? If that does not have any need, then you should really think of what you're doing. Can I have the next slide, please? So if you really look at the healthcare, right, what we all nurses and doctors see are patients with symptoms. What are symptoms? Symptoms are just an observable phenomenon, which is arising either from a defect or a disease. So the symptom can be either a headache, chest pain, to fever, etc., etc. So now let me take you through a scenario. See, if you have a headache, what do you do it? You say, okay, it's a simple headache. Let me take a paracetamol and then forget about it. So it can be right from a cluster headache to an SDH to a brain tumor. But initial stages, what we do is we take it very light, right? Small headache, let's go. But what if the headache is a chest pain? You take it a bit more seriously. And the chest pain, sometimes you say, okay, it may be a gastritis, let me forget about it. Sometimes you say, okay, it is a chest pain, let me go deep dive into it and look into it. So what I'm trying to emphasize here is symptoms are real blessings. If you don't have a symptoms, for example, if you have a person who's highly diabetic, what happens when there is a heart block? He doesn't get a pain, chest pain. And what you say is the guy went into sleep and got up and then they say it was a heart attack. But if the symptoms are there, he gets up with the pain, go to the hospital and then get the treatment. So symptoms are an indicator from God to understand there's something wrong which is happening. So in a hospital setup, there are a lot of symptoms, the synonym of headaches and chest pains, which keeps popping up in daily operations. But it's our ability to pick it up and prioritize, which help us to understand what exactly is happening to our operations. So what we do is whenever you have a symptom, like your headache, like your chest pain, you need to go deep dive into it and see what is causing this headache. Is it a cluster headache? Is it a brain tumor? Is it a SDH? Or is it a psychological effect? What you do is you do a lot of diagnostics to find out what the exact cause is. So when a symptom or a problem, when it comes in, what really you need to do is you need to dig deeper and find out the exact root cause. And most of the time, all the causes may be multifaceted. Especially when you have a problem, it can be a multifaceted problem. It may not be a single thing which is causing it. It may be a multiple thing causing this problem. So, and being in healthcare, right, we can't take things very lightly. It can't be like a headache. It has to be like a chest pain. The urgency should be so high, right? Reason being, see, if we do some mistake, what cost is putting a patient into a coffin, right? That's a grave mistake what we do, which is going to haunt you throughout your life. So you can't take the symptoms very light. When I say symptoms, these are signs which got close to you and say, listen, this is the place, you catch it, do a root cause analysis, fix your things. Otherwise, if you don't do it, you will end up in trouble. So let me just take you for a journey of a patient, right? To make you understand much more practically. So suppose a patient comes to the hospital and if it's scheduled for a surgery, what does it do? The patient comes in the morning, get the registration done. Then from the registration, they send them to an IP admission area. Patient get admitted, nurses come, take to the OT, go to the OT, checking done, and then the surgery is done. This is a normal process. So let me tell you a small change in scenario. Two patients coming in, one is Mariam and one is Aisha, coming for hysteroscopy. One is for hysteroscopy and one is for hysterectomy. Hysteroscopy, hysterectomy, and age is also similar, sounds very similar. Two biller clerks sitting next to each other, giving the ID. They put the ID on the table. One patient took the wrong ID. Say, for example, Mariam, who is for hysteroscopy, took Aisha's ID, which is for hysterectomy, with the same doctor. 10 minutes, 5 minutes apart, the biller recognized, okay, this is something wrong child did. This Aisha has taken Mariam's ID, immediately call up and tell them to exchange, right? The problem solved. But then you are inviting a bigger problem. That means there is somewhere there is a big process delay. That time you had a symptom, you identified the symptom, immediately you rectified, but you didn't go deep into it. Now, what if the same scenario, this thing happened, patient went into the IP looked at the card, didn't ask the patient, okay, Mariam, okay, for Dr. X, for hysterectomy, okay, get admitted, put the tagline, the tag into it. The OT staff comes in. Again, forget to ask. Nowadays, the major problem is the communication is very less, right? They go check the ID, check the ID with the case sheet. Yes, same patient. Took them to the OT, and what if it has end up in a hysterectomy for a hysteroscopy? So what we really need to do is these are indicators. When you get the indicators, go into it, deep dive into it, see where exactly the problem is, and start channelizing the problem, identifying the problem, and then do it accordingly. So if you can just go to the next slide, please. So, okay, the slide is not coming well for me, but whatever it is. So I would like to talk more than the slide. So in any problem solving methodology, what happens is, see, if you really look at any problem, first you need to define the problem. Defining the problem itself is a big problem. Right? So if you have any problem, you ask 10 people, everyone is going to look at through their lens and tell their version of the problem. That may not be the right problem. So what you really need to do, if you are doing an RCA, as a collective member, you need to ask people what is the problem. And you should be able to see through different lenses and come to a conclusion and define exactly what the problem is. That's where a group helps, wherein it is not biased, it is not your view, it's a group view. Yeah, this is our problem. Otherwise, in the same scenario, when I ask them, when you go ask them what is the problem, they say, okay, there was a nurse shortage, so OT was rushing, so we just have to pull the patient in. So their problem is OT is rushing. Now, if you ask the biller, if you go ask the nurse in the IP, they say the problem is from the billing. And if you ask people, different people will tell us different problem. But the actual problem over here was IPSD error. You have not done your IPSD well. Whatever said and done. It can be either educational problem because people don't know what is IPSD. Maybe your nurses know what is the importance of IPSD. But for a biller who is joined new, he doesn't know IPSD. He does not know the consequence. He said, what did I do? Just changing a thing. Why are you making a big fuss out of it? So you should be able to tell him what his small mistake is leading up to. So defining the problem is very important. Now, once you define the problem, please call out when the time is over so that I can shorten it. So once you define the problem, then you need to analyze, right? This analysis, again, should be data-driven. It can't be somebody else's view or one person's version of the story. And when you have a problem and when you call a lot of people to define the problem, to understand what has went wrong in this scenario, the wrong patient is ended on an OT table. If you ask them, you will have some good orators who's going to come and convince you it is the problem of the nurses, right? And then you will have a bad orator wherein he will not be able to convince, but the problem may be lying there. So it's very important. You need to be more of data driven to find the root cause. And once you identify the root cause, there may be multiple solutions for any possible problem. So identify the best possible solution. I put all the solution in. Again, the group identifies, look at the solution, select the best solution in it. Even if you have identified the problem, analyze the problem, put the solution in place. It is just a paperwork unless and until you have a very robust action plan in place. And then implement those action plans. Even after implementing, your process does not end. Go back and track and measure. So when you implement, you make sure that you have a tracking mechanism and measures to identify that whatever you put in is working well. Next slide, please. This is more of a jargon. I won't go for it. This is more of the theory of how do you do a root cause analysis. There are a lot of things which are there, but if you ask me personally, all of them are mostly on the theory, except for the fishbone, which you've been discussing now. The rest of it is more on internet, more on theory, more on book. It will help you pass exam, but practically you're doing it. But what I would suggest to practically to all of you is don't do too many things. Do some very little things which are robust. So fishbone, in my experience, fishbone is something which is really robust and which is really very helpful. Can I have the next slide, please? So two important thing is, number one is collecting data and identifying the potential cost. So as I said, brainstorming becomes very, very, very important. And then next one is cause and effect diagram and force field analysis diagram and the flow chart. So you'll definitely have a quality team in your hospitals which is running the show. So it is more for those people to have all those flow charts and those things. But as I said, quality is everybody's job. What our responsibility, right from the CEO to the cleaner over there, is to giving them inputs. And then once you identify this thing, so you'll have to look at WISE and other checks to make sure that things are in place. Can I have the next slide, please? So I want to spend some time on this slide on brainstorming. So this is something which often we miss, right? It's very important that when you have a problem, you brainstorm with people. Have different group of people in different time. Sometimes you may have to meet them differently, not collectively. Sometimes you may have to bring them collectively and then ask them. So this brainstorming is the key thing in any problem solving. So you will get a wide range of ideas and wide range of perspective of the same problem. Next slide, please. So I'm not going into the theory of it. You can please read it. So Sarah, can I? Okay. So I won't go into detail of the fishbone analysis. Rather, what I would do is I'll go into a problem so that you understand it much better. Samir and Sachin has covered a bit on what fishbone analysis is, how it is it has been done and rolled out in a hospital setup. So let me give you more color to it, highlighting a simple case scenario. Next slide, please. So this is something which we have done here. So the OT watch we manage, we run around 40 cases in 5 OT. So you can imagine the traffic, 40 cases in 1 OT and 4 OTs. So it's a heavy traffic area. And for a smooth functioning of OT, you need everyone, right from the person who is admitting the patient to the post-op ward, right, to make sure that the traffic goes seamless. So often problem what we have is delay, OT is free, anesthetic is free, surgeon is free, but patient not reaching. And then once you go and ask the OT guys, what is happening? They say day surgery unit is not bringing the patient on time. And now when you go back and ask day surgery unit, they say patient preparation is not done. So, and then you get multiple problems. So what we did was the entire team sat together and said, okay, let's do a fishbone analysis on this. So we took first thing as a process, person, process, clinical related thing and patient related thing. And after that, we started putting each line item, like the bones of the fish, the theory which you have seen earlier. And I would urge everyone to read about this fish bone after you hear this, so that it will give more insight on how practically these things are done. So on a process, what we looked at is we said we identified there is undefined TAT for task performed, right? For example, whether it's for admission, whether it's for shifting the patient from the DSU to the OT, there is no TAT defined. So first thing is, okay, so we said, okay, let's have a TAT. Sometimes it's so funny that the entire thing was good. The only thing which was putting a block is the runner, the person who's shifting the patient, has not shifted the patient on time. So we started putting TAT on all that. So there is a turnaround time for shifting the patient. There is a turnaround time from the time the call is being made to DSU to the patient coming in. There's a turnaround time from the time the patient steps in to getting into admission process. And then when we looked at the TAT, the maybe lack of guidance for the patient admission in the morning hours, because morning hours, since the OT is so busy, it may start much earlier, maybe 6 o'clock. But then inadequate staff is not there in the counter, etc. So it was a staff limitation and not because of our process. And then a delay in transportation from admission counter to DSU. So all of it, we understood that there should be a cultural change. There should be a TAT defined for process. And then there is a delay in DSU beds. And when we look at the personnel, right, involved, so as simple things like transport facilities, transport is not coming on time. That is why you don't have a person who is in the counter on time. That's why the biggest problem, that is OT, is not being able to be taken at time. So the driver who is getting the people from accommodation to the hospital does not even know the problem would he cause if he gets delayed. If he gets delayed, the entire OT gets delayed. So we started educating them. And then we looked at our patient-related things, right? Some of the patient comes in, but then no NPO. Some of part preparation is not done. Patient is not given adequate information before coming in for the surgery. So what we decided is we educated the doctors, we educated the patients. We started calling them pre-op and say, okay, tomorrow is your surgery. You need to be there at 5 o'clock. And these are things you need to do. And then in the other side, all patient-related things have been, now, number one, it has been rectified. Number two, we put check mechanisms so that somebody checks that these process which we have put is being carried out. And then coming on to the clinical related things. Sometimes the simple thing which was delaying is site marking. Site marking not done by the surgical team. So since we follow strict quality principles, we don't shift a patient without site marking. Now the entire process gets delayed there. Now we are waiting for the surgeon. Now surgeon is in the ward doing the rounds, or the surgical registrar is in the ward doing a rounds. Now to get a surgical registrar is a problem. So we put a process in place so that the site marking is done on time. And then we have defined a TAT for everything from admission to site marking. And then we started augmenting all this. And then when we look, we have a system wherein we have doctors who are coming from the clinic coming and operating. So what we identified is there are a lot of communication gap between the surgeons who are coming outside and operating and in-house surgery. So we put a lot of process in place. We communicate to all the doctors, but this communication does not reach the clinic-based doctors because they are not based out of the hospital. So we started doing that. So what happens when a difficult IV access comes? What happens in pre-op medication? So once we did put this complete fishbone, we started calling stakeholders in groups. We called the OT team. We showed them this and said, what do you think about it? What more you wanted to add on it? And then once it's been completely designed, we started putting process in place. And right now, things are much robust and we are able to run such big operations without much delay. So I think this will be a good practical thing for all of you. So after hearing this, if you go back and read fishbone analysis, you will know it much. I've not read these theory books, sure. What I do is I get information from people who are quality managers, etc., and I look at opportunities to learn from people. Next slide, please, Sarah. Okay, so what you really need to do in life is to ask the question why. They say 5 whys, why have no end? You can keep on asking why. So even to a thing like, I'm a nurse, okay, where I want to be after 5 years and what I need to be doing to reach there. Next slide, please. To give you a more practical color for this, see, you have a patient complaint. Patient is dissatisfied. Now you ask, okay, why is the patient dissatisfied? So it's because of an inattentive nursing staff. Why is the patient nurse inattentive? Ratio to staff patient ratio is too low, or why is the staff patient ratio is too low? It's because of unable to retain experienced staff. Why are we unable to retain staff? The staff turnover, staff is unfamiliar with process. Or if you have a food complaint, the food is not tasty, food is very horrible, is what you see in a patient complaint. You ask, why is the food horrible? Is it because of inexperienced cook? It is because your food budget is not big enough? Or is it, then we say, yeah, it is because of inexperienced cook. Then you ask, okay, why is there an inexperienced cook? Is it a shortage of inexperienced cookers because of too long hours of working? So you really need to ask whys, but this whys can't go unended. And from these whys, you need to pick up those indicators which you can modify so that the entire process has been streamlined. So one of the practical scenario which I want to tell you is, can you go to the next slide, please? Okay. So one of the challenges we had was what Samir was also mentioning, hiring nursing. So in GCC, hiring nursing is a bit more challenging than in India because you need to have them licensed. And even if they are licensed and when they land up here, the culture in India and culture in UAE is different. And the patients are different. Even though the same nationality patient, their expectation is different. Expectation management is different. That's one side of it. And second side of it, the nurse who is coming in has got a lot of personal thing, coming out from home for the first time, does not know what's the culture of the organization, does not need some time to land and run in the organization. So we did an analysis. We said, okay, there are multiple facets for this problem. So how do we solve this problem? Started brainstorming with nursing folks, started brainstorming with people who are boarded and asked them, okay, what was your challenge when you came in? So, and from there, we got a lot of gaps. So the challenges were, when they come here, there is most of them, when they come here, there's a practice gap, right? They went in for a maternity leave, and then now they got the license, they're here, then out of touch. And then we had poor hiring quality, and then, which is all mounting on to patient dissatisfaction. And it is also increasing our cost. Reason being, when a nurse comes here, it takes another 6 months for the nurse to understand what's happening. And then to put on job, to give a patient assignment, it takes a longer time. So this is the time where the entire nursing team, with the lead of Sarah, who heads our entire nursing, came up with a concept called NEST. So why am I bringing NEST here is, it is a product of brainstorming. It is a product of fishbone analysis, which came in. And this is such a robust program wherein we onboard nurses back in India, induct them to our process. So if there is someone who has got a gap in, if someone working in ER, am I overshooting the time? Please let me know so I can stop. Or someone who has landed working in emergency for a long time, but not touched a patient for 1 year because I've gone in for maternity leave. We give them a chance to practice on the manicure, practice from India, and then groom them from there. And even the cost saving part of it, right? When they come back here, they'll be able to land and run. Next slide, please. So these were the operational benefits what we got from there. So next program is on, and right now what we're doing is we're hiring people in India, grooming them from there, and then bringing them back onto the Middle East. Now, this also helps us to give a robust pipeline ready, train nurses, so that when we have a shortage, we definitely can pick up people from there. And it is really impacted on our patient care and customer satisfaction. So, and then the patients who come here, they create the bond and they understand our culture much before they land here. So for new joinees, benefit is comprehensive understanding of what is happening. So we do give them a DHA coaching so that by the time they come here, understand and relate to people who and get that cohort ready to come and board. Next slide, please. So I want to end by this quote: to solve a problem or to reach a goal, you don't need to know all the answers in advance. But what you need to know is, you must have a clear idea of the problem or the goal you want to reach. With that, I conclude, and thank you so very much once again for this great opportunity. Thank you.
Thank you, Dr. Shabas. It was an excellent talk. We will next go to Mr. Vivin. Mr. Vivin,
Yes,
are you
ma'am.
there? Okay.
Yes, ma'am. Here, I'll just try uploading my presentation again. In case it doesn't work, I request the technical team to take it over from there.
Okay, okay. They are sharing the screen. It's
Okay, yeah, sure. Okay.
Okay, start with. Slideshow, come back.
Can we have the presentation on slideshow? Okay, so in the meantime, I'll just start off. My experience with Six Sigma goes even before I came into this whole management thing. So probably I still remember long back when I was traveling in a bus once, I had one of my seniors from school sitting with me. So he happened to be a software engineer. He was working for Wipro then. I still remember that very vividly. And he was telling us basically what they do and how do they go about doing their job and all. And he was describing about this certain requirement in his company wherein when they'll write lines of code. So he was part of a project where they had a very strict requirement of if you were writing so many lines of code, how many lines of code can actually go wrong. It could not go beyond, or it should not be beyond that limit. So they had a very strict requirement of that. Now, out of curiosity, I asked him, so how do you measure this? That is where first time I heard this term Six Sigma. And he said, okay, at that time, I didn't remember what the numbers were. He said, okay, out of X lines of codes that are right, X lines of code should be, can only have defects and all those things. But in that conversation, one thing that struck me was, I asked him then, okay, is there any company or is there any organization or have you as an organization achieved it? Then the answer I got is no, we are far away from achieving it. But then there are a group of people in Mumbai who have achieved it, and they are not a software company. They are not a huge company. They are just they are people who deliver lunch boxes called as dabbawalas. And that day, this concept of Six Sigma, dabbawalas, it got stuck into my mind. And for me, it was always some sort of a fascinating concept. Then I went on to do my management degree, and there I learned a little bit. Then went on to do a certification on this, and that is where I learned about this concept a bit more. But I should give a full disclosure saying that whatever I say right now is through my limited knowledge of that certification and my experience having done projects on this. But then Six Sigma is a huge topic, huge as in a huge topic. Not 20 minutes, not 2 days. You can actually have a Six Sigma class or a course for probably 2 months, or can be made into a major course also. So that's the range that we are talking about in Six Sigma. Can we have this presentation on slideshow? The technical team there. Okay, I think there is. Yeah. Okay, I'll carry on with this. Somehow, not. Okay, so it's not moving into that presentation mode. No problem. We'll continue with that. So that was my initial introduction to Six Sigma, and that's how it started off. Now, this concept is very enigmatic. When you hear about Six Sigma, everybody has this thing about, okay, there seems to be something going on there. There is something totally alien or something enigmatic. But one thing that we all understand is once you understand Six Sigma a bit closer, you'll understand that how objectively has it been created, and the entire purpose of Six Sigma is actually to reduce defects. And how do you go about doing it very objectively? So this presentation is meant to be a very, very, very brief introduction, because as I said earlier, when you're focusing on something like Six Sigma,
Excuse me, Vivin, will you be able to tell them about the slides? Which slide you want, like?
Slide number 2. We can start off. Actually, I'll just skip from there. No problem. Even the first slide, if you can put on slide share.
Okay, okay.
Shall I continue?
Please, please.
Okay, okay. Yeah, on slideshow. Yes, yes. I see the cursor going there. If you could just put it on slideshow, it would be helpful. Yes. It's not coming up somehow. Okay. Okay. So it's a combination of two things. You see the numeral 6, okay, and you see the Greek alphabet sigma. Now we'll discuss about sigma and what it actually means. The 6 numeral actually denotes the 6th deviation. Now this is where the mathematical and the statistical part comes in, so which we'll be discussing in our next slides.
Hello,
Next
sir.
slide.
Hello, sir.
Yes.
Sir, sorry to interrupt. Sir, you can just tell us which slide we have to play here.
Slide number 3.
Slide number 3. Okay, right. Slide number 3.
Yeah, slide number 3. Yes, correct. Yes.
Hello, sir. Now is it visible?
Yeah, it is visible. If you can put it on and yeah, the slide share. Yes, full screen. Can you do that also?
Full screen.
Yes.
Just make it full screen.
Yeah.
Is that okay, sir?
I have not seen the full screen yet. It's still in the other mode, the slide mode.
We have already made it in the full screen from here.
Okay, probably it might take time to update here. Okay, no problem. So as I was saying, so what exactly is Six Sigma then? You will see that when you are going through this entire Six Sigma concept, there are various statistical process controls involved. There are various statistical measures involved when you're talking about Six Sigma. There are various ways in which you can collect your data, you can measure what you're trying to do, you can improve on what you're trying to do, control what you're trying to do. So is it a methodology? Then this whole thing about why do you do Six Sigma? So basically this entire concept started off with an aim of reducing defects in manufacturing. So is it a philosophy? Then ultimately, if you could put all these things together and you're achieving so much out of it, is it a management system? Now, these questions, if you were to ask in isolation, it would be like the old story of the blind man talking about an elephant when somebody is holding to the tail and saying that the elephant looks like a snake, and somebody holding on to the legs and saying that the elephant looks like a tree, something like that. So Six Sigma is an elephant of that sort. And when we have to see, look at it from a perspective of totality, Six Sigma is a combination of all these things. So a good Six Sigma project should actually be able to reduce your defects, should have measurable statistical process controls in it. You should have followed a certain way of how you would have collected the data, how would you move into the next phase of actually implementing it. And then overall, all these things should actually lead to a tangible change or a tangible improvement in the overall performance of your process. That's the entire concept. Next slide, slide number 4. Slide number 4, has that been updated? Slide number 4.
Yes, sir. From here, we have made it into slide number 4.
Okay, fine, I'll continue. So when we go into this concept, first thing that we have to understand is a little bit of a statistical mathematical part, which is the underpinning for this Six Sigma concept. Now, this whole statistical part revolves around the concept of Galton, initially by an experiment or an observation made through something called as a Galton board or a Galton board experiments. Now, the Galton board is something that you see here on the screen on the left side. On a Galton board, you have a funnel-shaped opening on the top. And what they observed was, when you dropped marbles or something of that sort, pebbles or something, always when you dropped a sizable number of them, they always almost took a similar shape, the same shape that you see in the image there. There is a graphic visualization of the same thing on the right side. Now, the interesting part with this experiment was, no matter how many times you perform this experiment, the shape of the graph that you received was almost same all the time. And you could change it with any sort of material. Initially you would have used glass, second time you want to use rubber or wood or whatever it is, it doesn't matter. You could have tried with different weights, doesn't matter. You could have used with different size, doesn't matter. One observation was always that the shape that it achieved ultimately was the shape that you're seeing there and the curve that you're seeing there. Now, this was the realization. Slowly, the statisticians started having that, okay, there is some overlying law of nature which seems to be coming out of all these population samples that we try to sample and graph. Moving on, next slide, slide 5. Yes. Now, based on this observation, the first statistician to actually come out with a mathematical representation and a mathematical theory on this was Carl Friedrich Gauss, who gave a name to this particular distribution or how this particular thing is spread out. And he called it as the normal distribution. So this normal distribution curve that you would have seen if you were to do it on a Galton board, how this particular things were falling in place. So this normal distribution somehow caught the fancy of all the statisticians, mathematicians, saying that, okay, this seems to be some sort of a law of nature where, sorry, almost all large population sizes, when they are plotted on a graph, you seem to receive this kind of a distribution. Now, if I were to give you a few examples of this, I've told heights of people in the world. We don't even have to take heights of people in the world. We can actually take heights of people, all the people who are attending this conference today, or height of all the people in a classroom. Now, in all our schools, we would have seen, in our class, we would typically have, like, let's say there are 100 students. There would be 10 to 20 students who are really tall, 10 to 20 students who are really short. Then you will have probably 60% of the students who are on an average in between, okay, in terms of height. The same thing goes with if you were to take something closer back home, like say blood pressure. So if you were to measure, you will see that the normal blood pressure reading you will receive for sizable people. You will see few people having less, few people having more in a normal population. I'm not talking about in a diseased population. So this observation is the basis for the statistical or this is the statistical foundation of the concept of Six Sigma. So when we talk about Six Sigma, the first thing that should come to all our minds is this particular shape or the normal distribution or the bell curve as we call it. Next slide, please. Yes. So once we have understood this concept of normal distribution or a bell curve, the second concept that we need to build on is something called as average or mean. Now, we are all aware of this concept of mean and average. It basically tells us, I'm not going into the very statistical definition, but then it broadly tells us the middle point or the middle of the entire data set. That's the mean of the entire data set. So once we have understood, okay, there is a population which is being in, which can be put in the shape of a bell curve, and the mean represents the middle of it. Then the next challenge for the statisticians were, okay, how do you measure the deviation from the mean? Now, this is where the concept of sigma came, or the standard deviations, and deviations started to get measured. Sorry, I'll just have some water. Deviations from the mean were measured. Yes, once this deviations were measured, each of these deviations were then given a certain percentage. Like if the first deviation, it's up almost 68%. If you're within the second deviation, it's within 95%. So on and so forth. Next slide, please. Slide number 8. Yes, and then ultimately they came to a conclusion, statisticians and everybody, saying that if you have a process which is at 1 sigma, that means you're doing almost, you'll be able to reach something called as a DPMO level. A DPMO is defects per million opportunities of 5 lakhs. That means you will have only a process yield of 50%. So if you were to do 10 lakh operations, sorry, 10 lakh operations, out of that 50% will only be right. Now, these operations can be anything. You can be doing vaccinations. Only 50% would be as per the standard. And when you come to the level of the 6th sigma, you will be making an error of only 3.4 per million opportunities. That means out of 10 lakh, the previous example that I gave you of injections, if you're doing 10 lakh injections, only 3.4 errors will be found in that 10 lakh injections that you've done. So that's the level of 6 sigma. Next slide, please. Yeah, so I have given here a few examples of 6 sigma. We'll take this time example that's quite easy and intuitive to understand. So like, let's say if you are a watchmaking company and you are quite obsessed about your process of making very accurate watches. So if you're a company who is operating at 3rd sigma, that means you will make watches which will make 3.5 months of error per century. So that means your watch, when it moves for a century, supposing that it moves for a century, at the end of 1 century, it would have lost 3.5 months out of the time that it is showing you. So that's the amount of error that we are talking about. If you come to the 6th sigma, the same, if you were a watch company so obsessed that you were making processes up to the level of 6 sigma, you would make only your watches rather would make an error of only 6 seconds per century. So that is the kind of output that you're looking at when you're talking about 6 sigma. Next slide. Yeah, one of my panelists had previously spoken about this, so I don't have to go into details. Once you've understood the statistical basis of 6 sigma, the next thing is how do you collect the data required for this? How do you collate them together? What is important and how do you prioritize? So for that, a tool has been given, which is called as DMAIC, which is define, measure, analyze, improve, and control. Again, I'm not going into the details of each of these. Each of these components, again, can be spoken about online. But then broadly, we need to understand that, okay, there is a method to actually doing that also. Next slide. Yeah, similarly, there is another tool called as DMA-DV, which is define, measure, analyze, design, and verify. When the first tool was mostly reactive, the second tool is proactive. Like you try to understand the challenges much before it is happening. And that's how this second tool is defined. Next slide. Now, Six Sigma, it gives a lot of emphasis on the practitioner, because as I said, Six Sigma is a huge topic, and even the best of the experts, they find it difficult sometimes in certain situations to implement many of the concepts. So there is a general understanding of how a Six Sigma practitioner goes each level on top. So somebody starts off with a yellow belt, then people have green belts, black belts, and master black belts, each having its own requirements. Next slide. Yeah, and with Six Sigma, there is another concept of lean. Dr. Sachin had already spoken about lean. So in with the concept of Six Sigma, the concept of lean gets added, and then this entire thing is termed as Lean Six Sigma. Now, when Six Sigma, it focuses on reducing the defects, lean actually focuses on minimizing waste. So both these things, ultimately, from an organizational point of view, is a positive. Next slide. Yeah, so these are some of the companies which have successfully implemented Six Sigma. As you see, we have something close to Rome in terms of Wipro and all. Next slide. Now, this is one slide that I was talking about in the beginning of my presentation. And this actually was the thing that stuck me regarding Six Sigma, at least personally, for me personally. Now, the picture that you see here are the Dabbawalas that I was talking about. Now, the Dabbawalas, they are a group of people who actually deliver lunch boxes in Mumbai, India. And they do it by collecting lunch boxes from homes of people and delivering it to their offices. Now, these people, they don't have any formal, most of them, they don't have formal education. Most of them, they come from rural backgrounds. Most of them, they have not heard of any management concepts. They have not heard of anything remotely called as Six Sigma. But when somebody did a study on them, a research was conducted on them, the results were shocking. Like they were covering an area of almost 60 kilometers. They were carrying almost 2 lakh tiffins, taking a time of 3 hours. And they were making only one mistake. That means only one missed delivery in 16 million transactions that they were doing. And the requirement for Six Sigma is only 3.4 for 10 lakhs. So that's the difference. So basically what I was trying to say is like, once the approach, like if you have common sense and passion for work, that can match any management tool, be it Six Sigma or whatever it is. So with that thought, I conclude my presentation. Thank you so much.
Thank you, Vivin. To conclude, I wanted to congratulate all the speakers, especially because these quality tools are not only for hospitals. We can use these management tools for any organization. Lean management is very, very important, which Sachin has elaborately discussed, especially for cost containment, because it primarily talks about waste management. And for me, I always feel that there are a lot of untapped human resource capacities are there in each organization, where lean management is very important. We can use that HR, we can reduce the HR cost. And also, once we know that lean management help us to use the resources judiciously, especially man, money, materials, and minutes. Particularly, this strategy or tool is very important for the government to use the tax money for infrastructure development and social security processes when, or if they are using the HR properly or use the untapped HR resources and effectively. And second, I wanted to congratulate Mr. Samir for talking about quality circle from his own experience. He shared it very well. And primarily, I wanted to tell everybody that quality circle, when we think about it, is not from the management, it is from the employees. And this is out of time work actually. And people who wanted to maintain quality in any organization, a small group can be followed. In any unit, they can make a quality circle. When I was taking classes for quality circle for Kerala University of Health Service, Kerala University of Health Sciences employees, I was telling them how to make a quality circle after 5 o'clock. If they are ready to stay for 50 minutes or 30 minutes, they will be able to make it properly. And each department can function very well. I hope this can be applied to any organization, and nursing colleges or allied health sciences, medical colleges, all. If employees are willing to do it, they can make wonders with quality circle as a philosophy of their practice and as a tool also. Then about Dr. Sheba's root cause analysis, I remember myself when I joined MIMS College of Nursing as principal, our result was about 26%. Now you know that our result is between 96 to 100% for nursing, and also improving the allied health sciences. I have done a root cause analysis, and I always used to ask 5 whys. And we found what are the root causes for this, especially the physical causes, human causes, and the organizational causes have been identified, and we could rectify it. So anybody in any organization, they can use this tool. And I especially thank Dr. Sherbas. He was talking about from his experience about how how he used this root cause analysis in operation theater. Being a specialist in anesthesia, he knows why patients are getting delayed for admission, how the surgeries are delayed, what happens in between transportation, all those things. And it was a wonderful talk, Dr. Sherbas. Thank you. Then Vivian, though he had a little bit of problem with sharing the slides, he also did a very good presentation on Six Sigma. Actually, lean management and Six Sigma or Lean Six Sigma, all these are coming together now. Six Sigma, when we talk or think, the best example is given by Vivian about the Bombay Dabbawala. They are not management gurus and all, but they have practiced it. And Six Sigma, when we think, we always, those who have learned research, those who have learned little bit of statistics, they know about normal distribution and Sigma, how much error, all those things. So when we wanted to reduce the defect, or we wanted 0 defect, we have to go for Six Sigma. And we know that there are different levels of belts of Six Sigma. I always think that this yellow belt, all those things has come from, because it has come from Japan. They believe in martial arts, like a black belt, yellow belt, all this has come from them. And anyway, I'm so grateful to the 4 of you being with us from different parts of the world. 2 are from Oman, 1 is from UAE, and another one is from Kerala, Kannur. Thank you. This is again technological advancement. People can join from different parts of the world. And we have participants from different parts of the world also in this conference. Once again, I thank all of you. Thank you very much. Above all, seeing you all in this screen is something great. And I feel so happy. Thank you all.
Thank you, Asma ma'am, and all the panelists for the interesting and very informative discussion. And now the floor is open for discussion. Any queries from the audience? Okay, thank you. So let us move forward to the next session. It is on documentation and quality healthcare. Once again, I invite our respected principal, Dr. Asma Bibi TM, to share with us the profound knowledge on this aspect gained from a vast experience. Over to you, ma'am.
കേക്ക്
Audio is not clear, Pradap. The audio is not clear.
legally the record. Hello, good afternoon. I'll be talking to you on document and quality. On our way, we will see what is documentation, what are the purposes of documentation, types of documentation, guidelines for documentation, and we will see what are the types of medical records, documents seen in a medical record, how to have custody and confidentiality of maintaining hospital records, how can we request for medical records, and finally a small note on nurses and documentation. Effective patient care documentation is as important as the delivery of care itself. It is an integral part of healthcare practice and an important tool to ensure high quality client care. If you have not documented the service, it didn't happen. Legally, the records created serve as the best evidence for patient information obtained and shared, the care rendered, the role of the healthcare provider, and whether the professional and legal standards of care were met. Health records are maintained in every setting where a healthcare professional interact with patients like OPD and inpatient units based on certain criteria. For example, the patient's diagnosis, procedure, or even the acuity of care required like ICUs. Healthcare professionals who document and collect patient health information should understand medical record or health information laws, ensure that they act responsibly and in compliance with applicable laws, and identify when expert legal advice. As a definition, documentation is defined as recording patient findings following principles of medical documentation and report writing. Patient clinical record should contain objective information, subjective information, where 6 C's, the client words, clarity, completeness, conciseness, chronological order, and confidentiality is maintained. And then third point is details of patient care. So patient clinical record contains both objective and subjective information. And then what are the purposes of documentation? The first and foremost is the quality of care. It provides evidence that care was necessary, describe responses to care, describe any changes made in the plan of treatment and care. The second point is coordination of healthcare, plan interventions, decision making about ongoing interventions, evaluation of patients' progress, and this is in numbers. Then other purposes are communicating and providing continuity of care, accountability and professional responsibility, legal document, financial billing or reimbursement, education and research purposes, risk management, audit, monitoring, and quality assurance, facility practice. What are the characteristics of good documentation? The characteristics of good documentation are accessibility of medical record, accuracy of medical record, correctness of information provided, and the comprehensiveness of the medical record, the consistency of the information, and the relevant record. Then there are different types of documentation. It can be either narrative, where information is written, then SOAP. This is organized according to subjective, objective, assessment and plan. Then POMR, that is organized according to patient problems. Then next one is function or outcome reporting. Just like SOAP note that demonstrates the effect of implementation on functional limitations. Then the other forms are DAP, data assessment plan, ADME, that is assessment, diagnosis, intervention, monitoring and evaluation. These type of documentations are available according to the hospital policy. We may be using guidelines for documentation. There are about 14 guidelines given by different agencies. The first one is objective and factual documentation. Second point is timeliness. Third point is use of space. Fourth point is use of abbreviations. Fifth one is follow-up. Sixth one is correcting errors. Seventh one, recording medicine administration. Then eighth one, recording assistance with care. Ninth, designated recorder in emergency situations. 10th, clarification of orders. 11th, recording a telephone order. 12th, interaction with other healthcare professionals. 13, client education. 14 is documenting an incident in healthcare record. Let us see one by one. Objective or factual documentation. This is the first point. Documentation should be relevant, related to the client care, not opinions or assumptions. Objective documentation is the result of direct observation and measurement. Example, if a client was suctioned, the documentation should include why the client needed suctioning, what the outcome was, and the client's response to suctioning. Then a recording should be CC flat. This means it should be concise, complete, factual, legible, accurate and timely. Then use appropriate terminology, consistent format for documentation, and take credit of care given, and sign completely using first initial, full legal surname and designation. This is very important. You have to take credit of what you have done, whether for good or bad. You should sign it with your full signature. Then timeliness. Documentation of an intervention should never be completed before it takes place. That means before doing something, you should not record. You may be thinking that you will do it, but if you forget, what will you do? So better document only after doing the procedure or procedure. Documentation in chronological succession reveals change pattern in a client's health status. All inpatient record must be completed within 7 days from the date of discharge, but preferably within 24 hours. This differ according to agency policy. Most of the hospital wants the discharge file to be sent after completing to the medical record section within 7 days. And we know that most of the time the patients have to wait for a discharge summary. Even if you write the discharge summary, the procedure for sending the medical record is not over. You have to look into the medical record where some lacunae is found, that has to be completed. All this has to be done. And within 7 days, you have to transfer this medical record from your ward to the medical record section. And all operative procedure report must be completed immediately after surgery. All medical records entries are to be dated, the time entered, and should be signed. Then frequency and amount of details documented are dictated by the facility or agency policies and procedures, the complexity of the health problems, the degree of client's health risk and risk of procedure or care, then certain electronic methods of authenticating the medical record, including methods such as password, access codes or key cards may be allowed or provided certain requirements are met. Then use of space. Documentation must not have empty lines or spaces, and the time when assessment and interventions were completed must be noted. See, if you are writing one line and then leaving another line, then going to the third line, what will happen? There is a space left. The middle line will be left. People can write something there also, and this may go for forgery. So better don't leave empty spaces in between. Then use of abbreviations. Healthcare professional need to know what abbreviations are acceptable in their agency and use only accepted abbreviations. Fifth point is follow-up. Follow-up of assessments, observations or interventions must be recorded. Failed attempt to reach a physician or other care provider, the follow-up action taken and the client's response to interventions, etc. need to be documented. Then correcting errors. You have to remember three aspects here. Whether you are correcting an error in a papered format or in an electronic format, or you wanted to introduce something which has been missed out or not written. In the three areas, that's documents in paper format. To correct an error in a paper-based healthcare record system, use slide rule. Slide rule is cross through the words only with a single line and insert your initials along with the date and time. That is slide. And then enter the correct information or explanation. Hope you understood the slide. Single line, insert initials, then along with the date and time, and then enter the correct information. That is slide. And some hospital uses other format like writing void or error or mistaken entry, etc. along with initials of the registered employee. When an error is made in the medical record entry, the original entry must not be obliterated, and inaccurate information should still be accessible. See, if you made an error, you can correct the error by using slide rule. You are not supposed to obliterate the corrections. You leave the error as such, crossing it with the using slide rule, and then enter the correct one afterwards. But you should not obliterate what is written there. Don't try to erase it like that. Then again, the correction must indicate the reason for correction, and the correction entry must be dated and signed by the person making the revision. Okay, corrections to electronic records. Examples of documentation errors that are corrected by addendum include wrong date, location, duplicate documents, incomplete documents, or other errors. The amended version must be reviewed and signed by the provider. Sometimes it may be necessary to recreate a document. Example, wrong work type, or to move a document, for example, if it was originally posted incorrectly or indexed into the to the incorrect patient record. Then when a pertinent entry was missed or not written, what we should do? The author must meet the following requirement. Identify the new entry as late entry. Then enter the correct date and time. Do not attempt to give the appearance that the entry was made on a previous date or an earlier time. the entry must be signed. Identify or refer to the date and circumstances for which the late entry or addendum is written. When making a late entry, document as soon as possible. There is no time limit for writing a late entry. However, the longer the time lapse, the less reliable the entry becomes. So, at the earliest, we must correct it. We should not wait for a long time. Then recording medication administration. Document the administration of medications immediately after its administration. The person administering medicine only should document it. No proxy documentation of medication is allowed. Registered nurses should only record medications they have administered. Then pertinent information to record as far as medicine administration is concerned related to the process of administering medications. The first thing is that, for example, that is self-administration, whether the patient has taken by himself or not. Then what are the questions the patient asked, whether the client refused medication or not. Then next, related to interventions, client education, what education you have given, whether the medicine has to be taken in empty stomach or medicine has to be taken after food, like that. Communication with the prescriber. If you have any doubt with the medicine, you may contact the prescriber, that is the doctor who prescribed the medicine. Then the third point is outcome of the care, therapeutic drug response and side effects in that. Then recording assistance with care. This is specifically important for nurses. When an RN, that is a registered nurse, assists another RN in providing care. For example, when assisting another RN to ambulate a patient or insert an IV, the RN providing care documents the actions and the client's responses and notes that another care provider assisted. There is no need to name the person who assisted. In critical incidents such as fall, record the name of the person who assisted. Then designate a recorder in emergency situations. When acting as a designated recorder, the recorder identifies the person involved and the care they provided. That must be clearly written. Then 10th point, clarification of orders. Never guess or rely on group consensus to interpret an order. You may not be able to read the prescription written by the doctor. You should not assume it is written as something else. So if you have doubt, you have to contact the prescribing doctor itself, not discuss with somebody else and administer medicine or do the procedure. You have to contact the prescriber who have written that. Nurses should clearly record the medicines by clarifying even the spelling with the dose and route with time and date. Put the signature of RN with RN number and write telephonic order or prescription if it is telephonic order. It must get countersigned by the physician at the earliest on arrival to the unit, because if you are taken a telephonic order, you should get it countersigned by the physician who. Then documenting telephonic order, write down the time and date on the physician's order sheet. Write down the order given by the physician. Read the order back to the physician to ensure it is accurately recorded. Record the physician's name on the physician order sheet. State telephonic order. Print your name, sign the entry and identify your status. If you are a nurse, write nurse. If you are an RN, write RN. If you are a physiotherapist, write physiotherapist. Like that. If you are somebody else, write your designation. It must get countersigned by the physician at the earliest on arrival. Then interactions with other health professionals. Record the outcomes or agreed upon plans of action and the names of the people involved. when it is needed, developing care plan, documenting on flow sheets, completing narrative or computerized documentation, and participating in team or family conferences. In all these situations, we may be interacting with each other as health professionals. So all these need to be recorded. Then client education. Document all client education with the extent of the client's understanding. Written education entry should be with the date and time and should include a brief description of the material taught. For example, if you have taught them the need for diabetic diet following a prescribed diet, so you write the material taught is on diabetic diet. The methods used for teaching: written, visual, verbal, auditory, or instructional aids used. You may be teaching them as a lecture, you may be using some models or some pictures. All this has to be written. What you have used, what method of teaching was used, what teaching aids were used. Then involvement of and the interaction between the client and the family in teaching learning process. Then evaluation of teaching objectives with validation of client comprehension and learning, whether the client understood what you taught or not. For that you can recapitulate, ask few questions and write whether they understood or not. Then the 14th point, documenting an incident in the healthcare record. A brief description of events without leaving the essence of incidents and setting. Include the names of people involved. Keep the time and date of the incidents. This is the last point in the then medical see types of medical records. Usually we talk about 3 types of medical records, that is the personal health record, electronic medical record, electronic health record. Then other records available in the hospital are patient clinical record, individual staff record, ward or unit records, administrative records. With the ward records, there are a lot of ward records, you know about it. Most of you have seen so many records in a ward. There will be a circular record to circulate among staff what is happening, if there is something new about it and all those things. Then there is a rounds book, the duty roster, ward indent book, ward inventory register, staff patient assignment record, student attendance and patient assignment book. What are the documents usually seen in a medical record? There will be identification information of the patient, medical history, medication information, family history, admission assessment, treatment history, medical directives, graphic sheet, follow sheets, vital signs, IO chart, that is in intake output chart, operative notes, lab results, consent forms, progress notes, nurses notes, patient education records, financial information, that is about insurance if available, if they have health. Then importance of medical records. It is the most important part of the records documented as far as patient is concerned. These are scientific and legal, evidence to patient that his or her case is intelligently managed, avoid duplication of work, information for medical and legal research, aids in the promotion of healthcare, health and care, legal protection to hospital and the nurse. Legal and ethical value, ethical aspects, adequate medical documentation assures patient confidentiality and ensures that the standards of care being met. Doctors and other health professionals have an obligation to treat illness to the best of their ability in regard to information documented in a patient's medical record. Then legal aspects, police authorities and court can summon medical records under the due process of law. Limitation period for filing a case paper is maximum up to 3 years under Limitation Act. That is, Medical Council of India says that we need to keep a treatment record of a patient for 3 years. Preserving the inpatient records in a standard performa for 3 years from the commencement of treatment. That is what MCA is asking. But according to Consumer Protection Act, it is up to 2 years. This is based on section 69(1) of the Consumer Protection Act 20. Then other legal uses: establish the applicable standard of care, evidence in civil actions, evidence involving credentialing process like NABH, ISO, etc. Then disciplinary proceedings of healthcare professionals, establish the cause of death, insanity conditions, patient's physical conditions, determine blood alcohol content, medical reimbursement for insurance companies, and the most important thing, defending against or preventing legal actions, workers' compensation actions, disability determinations, and claims of negligent or improper health care, and is generally admissible at a trial. The other uses substantiate billing for reimbursement, which I have already told you, need for present and future therapy or medical services. This will help you to find out what was done, past medical history. The consequences of altered, incomplete, and non-existent records can be legally and physically catastrophic. So remember that you should have your records properly kept, track. It is easy to track. Like that, in the medical records section, you should have it. It also serves to communicate with others so as to patients' can be determined. Then about custody and confidentiality of the medical record. The medical record is confidential and is protected from unauthorized disclosure by law and must be sent to medical records department or area upon completion of discharge of the patient. The medical record content shall meet all state and central government legal, regulatory, and accreditation requirement and timely completion. Sometimes shadow files may be kept in the ward, but the original file has to be sent to the medical records department after discharge, that is within. Then who may document entries in the medical record? Multidisciplinary notes are there. Employees of the healthcare system who are designated by the system only should enter patient details in medical record. They are doctors, nurses, other health providers like dietitian, technologists, counselors, MSWs, physiotherapists, and other therapists. Then how can we request for a medical record? If you are doing a retrospective study, you may have to go for backfire. There you have to request for medical records. How will you request for it? The Health Information Management Service staff will process the request for medical records for the purpose of treatment, payment, health operations, and also for research. All charts physically removed from medical record storage areas will be logged using computerized tracking system. Workforce members who access medical records for payment or healthcare operations are responsible to access only the amount of information in the medical records which is necessary to complete the job responsibilities. You are not supposed to study the whole medical record. You may need how much was the finance, what drugs was given, what was the treatment plan. Only that area you need to look into. The other parts are not. Then healthcare operations. Patient medical records may be assessed for routine healthcare operations purposes including peer review committee activities, quality management reviews, documentation reviews, and for teaching. Treatment. Healthcare providers who are directly involved in the care of the patient may access full medical record in accordance with the policy of the hospital. This may be for planning better care. Nurses and documentation. Why I wanted to tell this, some of the participants are, most of the participants are nurses. Nurses must not indulge in malpractices. A nurse has the right to refuse to assist any medical practitioner if he or she indulges in malpractice. So, this certain important things a nurse must remember. All what I have talked so far is important for all. But for nurses, usually they take telephone orders. Orders accepted over the telephone are generally made without the physician's direct assessment of the client's condition. So only the nurse gives the assessment to the physician through phone. So the major responsibility comes over the nurse. Your assessment should not be a failure. You should assess properly and give clear picture to the physician for getting a prescription through telephone orders. And this need to be documented. I have already told how to write a telephone order. And on-site verbal orders also have the potential for error and are avoided unless in an emergency situation such as a cardiac arrest. Nurses need to be aware of the agency policy with regard to accepting and documenting on-site verbal orders. Only registered nurses take verbal orders and even telephone orders pertaining to. Then, how are the after-the-fact notes developed by nurses for potential use in the future handled? There are occasions when nurses write notes after the fact. That is, example, 1 day later, 1 week later, etc. This is most often to provide clarification following an incident or an unexpected client outcome. Nurses usually write these notes while the event is current in the nurse's memory in case of an investigation or lawsuit at a later date. So you forgetting should write at the earliest. Nursing students and documentation. They are not registered nurses. They must record separately and get it verified by registered nurses. Then enter it in the documents and sign by them. Countersigned by the concerned registered nurse. No teachers or clinical instructors countersign as the patient is not under their care. Lot of controversy present in this matter. But actually, the teachers should not countersign as the teachers are not taking care of the patient directly. In nutshell, nurses' documents are legal documents. All legal documents needs protection. Nurses are professionals. They are liable to be sued. If nurses follow directives of documentation, future litigation can be reduced for them. All litigation comes from dissatisfaction on care provided. See that your patients are satisfied with your. Then Florence Nightingale pledge the foundation for modern nursing ethics. It has 4 points. Live a pure life and practice faithfully. Do not administer any harmful drug. Maintain and elevate the standard of the profession. Devote to the care of the patient. These 4 points are very important, and when you are considering documentation, this is much more important. As a conclusion, any written or electronically generated information about a client that describe client status or the care or services provided to that client. Care not documented is care not done. Remember, medical records are legal documents. It protects you and your organization from legal and criminal endeavors. These are the references.
Hello, good.
Thank you, ma'am. Audience, if you have any queries, can we get clarified? Any queries? Okay, that was the end of pre-lunch session. Now let's break for the lunch and please be back by sharp 1:30 p.m. Thank you.
Good afternoon, all. Welcome back to the afternoon session. Next session is a very significant one in the current scenario. That is disaster preparedness in the quality healthcare setup. We call upon Ms. Alfred George, Associate Professor, Department of OBG Nursing, to introduce the distinguished resource person, Dr. Venugopalan PP.
Dr. Venugopalan PP is a medical graduate of Calicut Medical College. He did his post-graduation in anesthesiology and also undergone special training such as Advanced Trauma Life Support Provider and Instructor under American College of Surgeons, Emergency Ultrasound Training from George Washington University, Advanced Ultrasound in Trauma Life Support from All India Institute of Medical Sciences, Delhi, Faculty Training in Emergency Medicine from George Washington University, National Disaster Management Certificate from National Trauma Society, India in 2008. Dr. Venu has developed and established international emergency medicine departments in Aster Group of Hospitals. He has also initiated and established International Emergency Training Program, Masters in Emergency Medicine in all Aster Group of Hospitals under George Washington University, USA. He has taken the lead role in training more than 2 lakh lay public in first responder provider program in Kerala in the last decade. Dr. Venu is the founder and executive director of Active Network Group of Lifesavers called Angels International Foundation and Trust, and this trust has bagged 2 international awards and 1 national award. Dr. Venu has 20 national and international awards to his credit. To name a few, Aster DM Healthcare 2016 award for his 15 years of continuous and meritorious service in Aster Group of Institutions, Bravery Award from Semi International for contributions in Chennai flood 2016, APJ Abdul Kalam Leadership Award in 2016. He received this award from Dr. Rosaya, Governor Tamil Nadu. National Excellence Award by Society for Emergency Medicine in 2015, etc. Dr. Venu has authored number of medical and non-medical books and journals. Presently, he holds number of professional positions such as Director Emergency Medicine, Aster DM Healthcare Group, India since 2014, ITC Coordinator and Regional Faculty, American Heart Association since 2010, Site Director, Master's Program in Emergency Medicine under George Washington University since 2007, Faculty in Advanced Trauma Life Support Training Program under American College of Surgeons since 2011, Deputy Director, MIMS Academy, Calicut since 2008, and National Faculty in Emergency Medicine PG Fellowship under George Washington University since 2007. Dear sir, we welcome you, and over to you.
Hello, good afternoon, and thank you for the opportunity to present this important topic to the August gathering. Today, I'm going to talk about disaster management is management plan in principle and preparedness. And also I will share a few experience what we had in the last year when we managed that Calicut airport disaster. So as you know, a disaster is a phenomenon that has a potential to cause disruption or damage to the people and their environment. The disasters can be either natural or man-made, like it can also be a major one or a minor one, both natural and man-made. So the classical, sometimes the disasters can be natural in man-made. Classical example, our Kerala floods, then Chennai floods, and also recent many landslides happen in Kerala. All this may be due to the man-made causes like filling wetland, unauthorized constructions, again, destructions of the hills, etc., and deforestation, etc. And any kind of disaster, the preparedness is the most important one. A classical example of beautiful and brilliant preparedness and which reduce the impact of the disaster is that a disaster which has happened in 2013 in Japan, which is a triple disasters happen together, which include earthquake, tsunami, and that nuclear gas leak. And another brilliant evacuation plan done in India in 2018, that is that biggest cyclone hit on Odisha, that is the Titli. And there they evacuated more than 3 lakh people. And this is one of the biggest evacuation plan ever happened in the world. And the death of this particular incident is only like in numbers that we can count in our fingers. So at the same time, you think about the Oki, is another disaster happened in 2000. It is in 2017 in Kerala and Tamil Nadu, which has got 318 people lost, and for 141 still are missing. And are we really prepared well for this incident? That is the real questions. And as far as the disaster preparation is concerned, the key points include mitigation or prevention, which involve structural and non-structural measures that should be taken to limit the impact of the disasters. And this can be achieved through risk analysis, which results in information that provide a foundation of mitigation activities that reduce the risk, and insurance that provide financial investment for those who are involved in the disasters. And another one I want to tell about the disaster management cycle. When a disaster is struck, and it will follow a sequence of events, immediately once the disaster is happened, it is go through the disaster relief, rehabilitation, and rehabilitation assistance and mitigation assistance. And the disaster has got both short-term effect and long-term effect. The short-term effect, which is solved, is managed by rescue and relief. That is the part of immediate disaster relief. And part of the rehabilitation assistance, we will do the real rehabilitation. And also we will do that reconstruction, what all the things damaged that will reconstruct. When this is over, then we will enter into the mitigation phase. In mitigation phase is constitute mainly the preparedness. And when this is something like it is follow a cycle. And see, like the disaster planning, we know like the cyclone and our rainy season happen in about the May and June. For the preparation, we should start from January to April. And once the disaster happened, it was managed, is management of the just before management, just after management. After that, you have to follow that immediately after the disaster, you have to do the rescue, relief, rehabilitation, and then move to reconstruction. So this way it should be approached. Now, the most important of this today's topic, how the hospital to be get prepared. You know, like the hospital need to be prepared in any kind of disaster, because the hospitals are the first institutions to be affected after any form of disaster, and are the hospital, whether this is that whether the disaster is a natural one or a man-made one, or yeah. So we need to prepare our doctors, nurses, paramedics, and other hospital staff to face and to manage the critical scenario what is happening during the disasters. So two terminology I would like to bring about while managing an hospital preparedness during disaster. One is a mass casualty incident, or MCI. A mass casualty incident is any incident that exceeds that responders or the receiving hospital capacity to treat or to transport. That is called a mass casualty incident. But the other one is a multiple casualty incident where the resources are not overwhelmed, but there will be a multiple victims that who are involved in the disaster will bring to the hospital. So what's the disaster management we have, like we need a pakka documented plan for both internal disaster as well as external disaster separately. So you need a systematic approach in this regard. And the systematic approach which include like a command and control, safety, the safety of self-safety, scene safety, and survivor safety. Then communication. Communication is the methane communication. That I explained what is the methane communication. Communication is the cornerstone of any kind of disaster management. Then assessment. Then T is the triage, treatment, and transport. Then evacuation, reallocation, and redeployment, and sometimes reconstruction. These are the basic components for any kind of disaster management. So, so you can remember all these 7 components in a components, just remembering the name disaster through the mnemonic disaster, DISASTER, disaster. So what is this paradigm? This paradigm is a D for detection, I for incident command, S for safety and security, A for assess hazards, S for support, T for triage, transport and treatment, E for evacuation, R for reallocation and redeployment, and also maybe reconstruction also under this R. So the detection, you have to detect that the disaster once has happened, whether it is internal disaster or an external disaster. Internal disaster means a disaster which happened inside the hospital, and an external disaster is something outside the hospital. So again, that disaster can be two-way. Either it can be standby or it can be declared. And suppose someone is saying like a plane is about to crash or it is coming, and we are anticipating a plane crash, means it's a disaster standby. A disaster declared means something happened and the plane is crashed already, and the casualties are started to send you. This is a disaster declared. And once a disaster occur, you need to be like a cordon off the zones. These zones there are 3 zones as far as the disaster spot is concerned. This is the bronze zone, silver zone, and gold zone. The bronze zone is the zone that is exactly situated just around the disaster incident, place of incident. And the zone next to it is a silver, and outermost zone is the gold. Why we want to set such a zone? This is mainly because of the disaster to make easy the disaster management, the disaster management and its proper execution. So the most important thing, the innermost zone only like where that rescue units to be entered, like fire force and other trained people. And in the second zone, in the outer zone, in the middle zone, the civil defense, army, fire and rescue police, smart team, all these people, and the command, on-site command post, that will all situated is in the mid zone. And in the outermost zone, mortuary, then rest area, victims, family center and the counseling center, then food and other beverages. All this will be including media and all. In our country, most often like that media and VIPs will go to that innermost zone. That is something dangerous. They should be situated only in the outermost zone. That is the whole idea of this zonalization and the cordon offing the zones as far as disaster management is concerned. And the zones is zones color zoning is slightly different in cases of fire explosions and toxins, where the zones are red zone, orange zone. Red zone is the innermost one, orange zone is the middle one, and the blue zone is the outermost one. This we decide depending upon that intensity of the fire and the explosion pressure and the toxic fumes, the concentration of the toxic fumes uh, in the atmosphere. The most important thing is like when we are setting up that services, we should consider the wind direction, how we have to do. Like suppose the wind is direction from the east is to west, the command zone, support area, so etc., should be placed in the area is from opposite to the wind direction. Suppose the wind is from west to east, all our command center and other areas should be in the west side, not on the east side. Now, this is about the detection D. Then we will come here to the incident command. Incident command is basically born from the fire services. Just got a uniform structure. There will be clearly delineated roles and responsibility. They have a clear chain of command and communication. So they have like multiple people under the incident command. There will be planning session, operations, logistics, finance, security, press, media, all these coming under this incident command. In one point, everything is to be coordinated by incident commander. And next one is a support. To manage a disaster, one person alone cannot manage. It can be managed only with the support, depending upon the type of disaster, whether it is a national disaster, state disaster, or district disaster. That support should come from the national government, state government, then fire department, law and enforcing agency, police, local government, etc. So next one is assess. Whenever a disaster occurs, we should aware of the hazards. So we must be like assess the hazards that can be particularly in secondary devices which cause hazards, then bombs, then incapacitating devices, multiple snippers, terrorists, delayed devices. All these we have to consider, and we have to see that these are not there. Next is the second S. This S is the means to ensure the protection of, that is a safety and security, through which we have to ensure the protection of the staff who are handling the disaster by using personal protective devices, then decontamination policies, particularly in a toxic fumes, a toxic exposure, proper decontamination, and also you need to be like a proper isolation protocol. Next one is the most important, the triage. Triage, is like one of the major component of the disaster management. It is a process of prioritizing patients based on the severity of their condition in order to treat as many as possible when resources are insufficient. This is basically a triage. So the triage, the ultimate idea is like take the right patient to the right place at the right time in a right transport mode. And depending upon, we can do for the triage purpose, we can categorize the patient into red, yellow, green, and black, depending upon the severity of the injury and their urgency. A red one to be addressed immediately, yellow you can delay it a little bit, green you can be wait, and someone is died on the spot, should be marked as red. So how will you do such kind of triage in a field? That is something a challenging one. Suppose in an accident, there's 100 people are involved. To sort it out, these people on the spot, you can use a triage sieve. In triage sieve, what you will do, like you need whatever you are telling, you need to be like a very commanding voice and a loud, clear voice. Any emergency, your communication should be very prompt, loud, and authentic and powerful. And also in this, suppose 100 people are involved in a scene, you can use a commanding and public announcement system, which is available in ambulance and reliable with the police, etc. on the field. So what you have to do, the first thing you have to segregate out that those patients who can be walk. You can ask all the patients who are able to walk and such able to stand and walk. This patient could be segregated out, or they can move out from the scenario first. They will be tagged. They'll be tagged as green. All these green people to be first removed from the field, and they will be communicated and will be reassured by someone. You have a good communication capacity. Next is like you have to individually go and see each patient. For that, like those patients who are not able to walk, what will do? So you go and nearby and look at his breathing. If he is not breathing, what you will do? You try to open his airway or to look for any kind of movement or any respiration. If no respiration, what you will do? You will put it as black tag and they designate it as that. If they have some movement or some respiration, they will be designated as red and put in the red tag. That kind of people transported immediately to a higher end hospital. Then coming back to looking at the breathing, if the breathing is present, what if you look at next? If the breathing is present, you look at how is the breathing. Is the breathing is normally or not? If the normal means if it is breathing between 10 to 30 rate. If he's abnormal breathing, he is breathing fast or slow, or he is an abnormal pattern of breathing. If it is someone is not having a normal breathing, is again, someone is having abnormal breathing. Again, this is also dangerous. You mark it as red. And if he is breathing normally, then you look at for the capillary refill time. Is the how this capillary refill time is normal or not? If the capillary refill time is not normal, again he has some blood loss and all, he is also marked as red, tagged as red and transport early. And if his capillary refill time is normal, then you go to the patient and again you ask a simple question: what happened, what is name, etc. For ask him to follow simple command or protrude the tongue out like that. And if this command, if he is not following properly, again he has got some head injury or his conscious level is not okay, and that patient is also like you have to mark red and transport immediately into the out of the field into a higher end vehicle. All the red category patients to be transported in a mobile ICU kind of vehicle and transported to higher end hospitals with all facilities. And someone is follow command normally. And what will happen is these are the only people in remain on the field. They will be tagged as yellow, and after red you transport yellow, and after yellow you transport green. This is the way you apply that safe triage. So you can use that ribbon for the as a triage tape, or maybe triage tags or tapes are available. And sometimes triage tag, printed tags are available. So you can, whatever is available, you can use it. Next, coming to the T is the treatment. Treatment include once reach in the hospital, they required multiple medication, antidote, antibodies, antibiotics, immunization, prophylaxis, then chelation in the case of toxicity, etc. It's a way the part of treatment. So, what is next? Yes, next T is evacuation. See, like in an event of a disaster, sometimes a hospital might need to be evacuated either partially or fully to accommodate the casualty. Sometimes you have to quarantine or divert that incoming patient. And like sometimes all the cases like flood, you have to evacuate over the ground floor to another floor. And like one of the major evacuation happened in 2018 in Kochi, our hospital that is in Astramed city, Kochi, completely evacuated. She included nearly 450 patients, including 100 critically ill patients on ventilator. So all patients shifted to another center. So sometimes, like you may have to shift the operation theater and sometimes you may be arranged in a temporary operation. Again, a minor surgical procedures in victim may have to be undertaken in those areas, which could mean altered level of asepsis like that you can do. So it's kind of arrangements may have to do in the management. Then evacuation. Sometimes you may have to convert various parts of the hospital, like hospital lobby can be converted. Sometimes auditorium may be converted, corridors may be converted, parking area may be converted, prayers can be converted as the patient care area. You know, like here it is the field hospital we constructed in the second wave of COVID pandemic in the last year. We constructed a field hospital in the car park area. You can see the inside and outside. Sometimes, like the patient may be shifted to another hospital if our services are overwhelmed, and for that purpose, you need to have the complete contact numbers part of your preparation, and also you need an MOU with this kind of people, other institutions. It's all to be placed well early, not once and disaster happen. It will be sufficiently early. Then, like the major disasters, sometimes you may have to open relief camp. You have to evacuate people from affected area and prone area to the camps. Again, you may have to run the medical camps. It's all the part of disaster management. Then, like one is a reallocation. Reallocation means that allocating the scarce equipment, if any in a way that serve that the largest number of lives, in contrast to the traditional focus of living individual lives. And sometimes you reallocating non-emergency and non-clinical doctors to emergency areas. Sometimes you recruit retired or unemployed person for the temporary service. It's a part of reallocation. Then last part is that recovery. In recovery, you know, like you re-establish that once everything is settled, the early part is settled, then you start reconstructing the infrastructure. In this phase, you need to give psychological support. And for the people who involved in the disasters, then you may have to help in the economic recovery and the insurance claim, like that. It is a long process. And the key component is like ensuring adequate supply of the qualified healthcare providers who are available and willing to serve in a mass casualty event. For that matter, you need to be extensive training and compassion. And finally, this, like, you know, like a few practical tips I want to share while you are executing that hospital disaster management plan. This is like, you know, once you place a plan, and you need to be check it periodically. It should be it is not merely sitting on the document. It should be like coming into the practical sense. For that matter, what you do as a hospital emergency response plan shall be undergo periodic assessment and evaluation whether the plan is addresses in all issues, whatever you are placed it. And so again, like every hospital has to identify the disasters that can be happen their premises. Suppose in Calicut, we have to identify what all the specific disasters can happen in our area, like a river, there's a flood you can happen, and a drowning you can think about, then toxic fumes you can think about, then plane crash, like rail accident, like that way you have to identify the real disaster can happen in our locality. So according to that, you can customize whatever the national document placed by the national NDMA or state DMA, and which we customize according to our local needs. And not only that, you have to execute that document appropriately, and you need to have like network the people. So what you want to do, like you have to identify, you have to customize, you have to execute, and to the network, then only that it will coming to the effectiveness at the time of an disaster strike. So for that matter, you need to be a lot of exercises you have to do. You can do a computer-based simulation. You can do tabletop exercises. You can do mock drills. and you should do like the post drill evaluation and put the corrective measures and make sure that that kind of corrective recommendations to be correct, or the non-compliances or non-conformities will be corrected appropriately on time-based manner. And you have to close that kind of non-conformities. Then only it will be going to be an effective one. So communication is the key word in case of any disaster. Everything depending upon communications. So you have to use like internal and external communications to facilitate or to in a case of a disaster response. Then you need to be having an updated phone numbers in your directory. You can use social media, you can use cell phone, you can use landline, you can use walkie-talkie, amateur radio, or whatever kind of communication, or TV, all these you can use, whatever the communication mode is available, you can use to spread and to give that correct message to the people involved in it. And when a disaster happen, how you do a properly communicate, where you have to use like rather than give a haphazard and indistinct communication, you must give a distinct communication. And every communication, if you announce or if you communicate to someone about that, or to give a handover to communicate about the disaster, it should have like you can remember through a methane communication, or the communication include all the methane components. This methane component, M is my call sign. You tell who am I? I'm Dr. Venu. I am calling from. Like that, you have to start that. M is for the my call sign, and also you mention what kind of incident is a major incident, minor incident, whether the incident is standby or declared. This is this is comprised of M. And E is you have to give the exact location, and T you have to give that what the type of incident it has happened. And then you mention about the hazard, whether it is hazards is present or it is potentially there will be an hazard. And also you have to mention like how to reach that particular scene. That is about the access. And again, you have to mention how many casualties are involved. And what level of severity. Suppose it is 100 people involved, you tell about 15 people are severely injured and 80 people are moderately injured, like that. And also you have to mention whether you required an emergency EMS service, if it is there, what kind of ambulance, how many number. This way, like if you are giving to an information to the hospital or the district authority or any person, this must component should be there in your communication. This is what is called methane communication. And while handling, beware of like fake news in social media. Social media is a good tool to manage the disaster. At the same time, some crooked people will utilize this in other way, and they'll spread the fake news that will create a lot of ambiguity, unwanted tension, and anxiety among the people. And this in social media helped a lot in Chennai flood and Kerala flood, and even in Kozhikode Nipah outbreaks. But even the COVID pandemic, a lot of fake news. Or even I know like people spread the fake news in my name in the COVID second wave, and even in the third wave. And finally, this here it is how you manage media. Media management is extremely important. You cannot manage the media haphazard. In Kerala, and you can see like 40 printed media, 40 visual media, and n number of online media, n number of all there. So when they are addressing there, it should be addressed where in a place where a designated room, and you have to address a designated person to communicate to media. Better to give like a periodic medical bulletin rather than giving this information here and there. And all information should be shared is based on the consensus opinion and consensus from the experts who are involved in the disaster management and patient management. So finally, I will try to share our experience in the Calicut plane crash. As you know, like after MIMS, we managed the major chunk of patients individually in Calicut plane crash. This we designated as Black Friday. It is a Black Friday, which is happened on August 7, 2020, and the disasters were declared at 1941 hours on 7/8/2020. So the main challenge of this disaster was all the plane craft came travel to the Vande Bharat plane traveling from Dubai to Calicut in the COVID scenario. So all the patients, all the victims are potentially the candidates for the COVID positivity. When we are getting the alert, our hospital was almost full, and we managed that entire scenario with the COVID pandemic precautions. And like those days, there was heavy raining outside, and also we have some uncertainty whether how many number of patients turning out or into our hospital. So once we received that alert, we announced mass casualty, mass casualty code, and immediately what we'll do, like we evacuated our non-coronary area, non-corona area of our main ED, and this area converted for the red area to receive to manage the patient. Our nuclear medicine area is converted into yellow area, and radiology reception area converted for the green patient, and the 2 ward exclusively evacuated and is reserved for the plane crash patient. Here you can see our emergency department people are prepared to receive that red patient in main ED. Here this is our nuclear medicine area, one is the radiology area. We managed that entire scenario with the full PPE. That was a big challenge. We've never faced such a disaster management situation even before, any time before that. So continue our plane crash or mass casualty incident sequencing. So we stopped all the regular work in the radiology department. All the area is reserved for plane crash patient. OT activated. 10 bed is reserved in medical ICU for the crash patient. Hospitals supplied enough and more PPE and other materials to manage a large number of people. We dispatched 5 ambulances to the site. Then pharmacy blood bank activated and mobilized enough blood and other medications to the emergency department. Then incident come and took over the charge. And then operation team activated, security is positioned, then relation and customer care department, finance department, food and beverage, all are positioned, and they started working on that. We opened an exclusive patient waiting area for the crash patient by Sanders, and we erected a separate dashboard for the patient information system for the cash patient is concerned, and we opened a separate media briefing area and to give the time-to-time information to the media and press. And the 7:30, that the incidents happened. We announced this mass casualty code in 8:22. And by 8:35 in the night, in the evening, we received the first patient, and we received the last patient on early morning, 1:10 a.m. And all the mass casualty is called off by 12:30, 12:35 a.m. And all patients stabilized, did their early stabilization and shifted to respective secondary destination area by around 12:50 in the morning. So all mass casualty, all patients by Sanders called and briefed. All the briefing is over by the early morning 3 a.m. and all by Sanders is taken to their victim and the wards by 3:30 a.m. So totally, we received 49 patients. Out of these 2 patients, 49 patients on the same day, and 8 patients after in the next day. And after the 49 patients, 2 patients referred out, and totally 47 patients treated in our hospital for their complete treatment received from our hospital. So all this story was portrayed very well in Indian Journal of Orthopedics, which was published in the 16th July 2021. And like out of the 47 patients, 38 of them are orthopedic, major problem are orthopedic issues and fractures and other things. In the entire mass casualty scenario, 74 doctors, 76 trained staff, and 58 supportive staff included, and they managed the show beautifully. And we received 17 red category patient, 19 yellow patient, and 7 green patient in the entire scenario. And out of these, like 9 patients in the red category are pretty bad, and they resuscitated and managed. And 2 patients had spinal cord paraplegia of the red category, and another 2 patients had paraplegia in the yellow category. And we had like 3 deaths on arrival, which include the pilot, co-pilot, and then 1 child, and another patient who died in emergency room within the 3 hours of the arrival during the aggressive resuscitation. And see, like the major injuries were the long bone fractures. Also, like there are 12 spine fractures and 4 paraplegic. All paraplegic patients recovered fully, almost fully, when discharging from the hospital. So one important point I want to mention, like, we have that point of care COVID screening, which was manned by ED EMTs. It is placed in the emergency department. It was a great help in the screening all the patient quickly and effectively. So we finished all the screening, the COVID screening, by early morning 7 a.m. And there were 2 positive cases. We could say protect all our staff, doctors, and other employees who involved in the mass casualty management. Another story I want to share, that we heard a mock drill in a mega mock drill, which was conducted in Calicut Airport, the same place where the present crash happened, that is in 2022, which was done by Aster MIMS, Angels, Calicut District Administration, IMA, etc. And he's like, in this mock drill, we trained 857 airport staff and 250 lay people before the mock drill. And then, like, we simulated a plane crash, 200 passengers on the board. And in the plane crash scenario, we have like 500 volunteers, doctors, paramedics, EMTs, nurses, medical students, all are participated. All these 150 patients we transported in the part of the mocking from various hospitals in and around airport, that include Kondoti, Peridhalmanna, Malappuram, then Calicut, MIMS, Medical College, Baby, and all other hospitals. And we had 175 ambulances participated in the mock drill, and we heard a post mock drill report, and which was submitted to authorities. They taken many appropriate and many corrective action. So this mock drill was very, very useful, and it was very helpful while managing this scenario. Well, it is made easy that present real scenario 7 in 2020. So finally, when concluding this session, the lesson learned for the entire Calicut mock drill is managing a mass casualty incident and a disaster in a pandemic scenario in full PPE was the biggest challenge ever we faced. And the plane crash, which has happened in 7:41 p.m. and the patients were reaching the hospital by 8:30. It was that shifting time for the nurses, etc. So this was really helped us for managing to get more stuff. It was very easy because of the shifting time. And point of care COVID screening in the emergency department, which was made that the screening process quick and more effective. And quality accreditations, frequent mock drills, and table talk exercises, which are made the disaster management easy. But I would say, like, that the pre-hospital care which has happened in the last 2020 plane crash is not fully okay. But still, like the accreditation like NABH, JCA, all these are really, really helpful while managing such kind of scenarios. So thank you so much for your patient listening. If you have any question, you can ask now.
No. Hello.
Yes.
Thank you, sir, for sharing your knowledge and experience with us on this very relevant topic, especially on how well the aircraft disaster was managed effectively in the middle of the COVID-19 pandemic. The session was made very lively with the real life incidents. Thank you, sir, once again.
Thank you so much for the opportunity. It is nice to talk to you all and to see you all. Thank you so much.
Moving on to the next session. The next session is on the key performance indicators for performance appraisal for nurses. I request Ms. Alfrin Jose to introduce our next speaker, Dr. Savia Fernandez.
Dr. Savia Fernandez is a renowned professional with more than 14 years of experience in various sectors of nursing. She completed her BSc Nursing from MS Ramaya Institute of Nursing Education and Research in 2002 and MSc Nursing in CTVS from Bombay Hospital College of Nursing in 2010. She also pursued her PhD from MGM Institute of Health Sciences in 2019. She has also done internal counselor program on NABH standards in 2013, Quality Care Lean Six Sigma for Healthcare Yellow Belt, and JCI standards training in 2017. Dr. Savia is a member of Board of Studies Nursing at MGM New Bombay College of Nursing, an active member of TNI Millennium State Branch, Navi Mumbai, external faculty of MGM New Bombay College of Nursing, and an expert member of Selection Committee for ACTREC Tata Memorial Hospital. Presently, she is the nursing superintendent at MGM New Bombay Hospital. We welcome you, ma'am, to this session and over to you.
Thank you, everyone, and a warm good afternoon. At the outset, I would like to thank the organizers of MIMS College of Nursing for today's conference and giving me an opportunity to speak on the topic, key performance indicators for performance appraisal of nurses. So today's objectives would be to define a performance appraisal, to enumerate the aims, needs, purposes, and concepts of performance appraisal, to highlight the benefits and limitations of performance appraisal. Then we'll go to define the KPIs, to explain the KPI process, and to depict the disadvantages of KPI and solutions to problems. So nurses are a critical part of the healthcare workforce and provide a significant proportion of care. And the success of any healthcare intervention depends on the nurse's ability and willingness to provide quality healthcare services. So a well-implemented performance appraisal management system can be a valuable asset in ensuring that nurses are motivated, promoted, trained, and rewarded appropriately. Performance appraisal helps to improve the organizational health, the viability and growth through optimal utilization of the nursing staff in the interest of the organization. So the ultimate goal of performance appraisal is to ensure a safe, effective patient care. Therefore, performance appraisal is a required process in healthcare organizations to ensure that the quality of care is met. In a recent feedback survey of the employees in 2016 suggested that around 68% of employees who receive accurate and consistent feedback feel fulfilled in their jobs. So what's performance appraisal? According to Flippo, a prominent personality in the field of human resources, states performance appraisal is the systemic, periodic, and an impartial rating of an employee's excellence in the matters pertaining to his present job and his potential for a better job. So why do we need performance evaluations? Basically, they provide a review of a past performance. So you exactly come to know where an individual stands, with the years of experience or with the knowledge gained over a period of time, and what is the gain in his or her skill sets. It establishes lines of communications. This is basically between the employee and the supervisor or the manager, or the staff or manager relationship. You make it very clear what you expect of the employee. You make them understand what are their strengths, their weakness, what they need to work on. So the lines of communications are very clear. It creates an opportunity to discuss professional development, goals, and objectives. So if you are a nurse in your department and your manager walks in and they see that you are quite established, you know the protocols, you are quite skillful, and they would give you additional responsibilities. So this is discussed at the time of your performance appraisal, based on which you will be given higher responsibilities, or you will be earmarked, or your responsibilities will be earmarked. It also helps us to document an employee performance. You may have records, you may have a checklist, and you will exactly pen it down, or like what exactly you have found good or bad in that employee. It also helps us rather to document corrective actions to improve work performances. Like when you find your staff who is lagging behind, has some challenges, you will organize the trainings that are required for them, for their upliftment or their upskilling of your staff. So here you will identify the key training needs of your individual staff. You will plan the trainings, and once the training has been done, you will evaluate the staff for their skill sets or their knowledge level or whatever you have decided the training on. It also gives responsibilities to managers to monitor, evaluate, and coach their employees. So this is our overall development of your staff. It's not the end of the term or once in a while that you sit with your performance evaluations, and that is the time that you will want to speak to your staff about their strengths or their weaknesses. This has to be a continuous process. Your staff has to be evaluated. Before that, they need to be monitored. You have to be as a manager, you have to be very crystal clear what you want to monitor your staff on. What are the things that you are looking for? So these things have to be highlighted and planned initially. So based on that itself, you can go ahead with your performance appraisal systems. So what are the basic aims of a performance appraisal? Basically, we need to give an employee a feedback. Everybody looks up to it, right? Everyone wants to be appreciated, to be, guided when they are at a workplace. We also need to identify the employee training needs, that what I have just spoken about, what your staff is lacking, what are their weaknesses, or in case you want to start off with a new department, or you want to start off with some new facility, you need to train your staff before they try to handle that equipment or try to face those patients coming for that facility. You need to document your criteria based on which you are going to appraise them at the end of the year, or every 6 months, whatever you decide as an institute. Form a basis for personnel, that is, you will look into their salary increases, or whether there'll be any promotions, whether there'll be any disciplinary action, bonuses, etc. So you need to formulate a base on which you would structure these. At the same time, it provides the opportunity for organizational diagnosis and development. When you have skilled staff, you have well-trained people on board, who can handle critical things, as one of our previous speakers have mentioned, how they have handled disaster preparedness, because they had an excellent training program and their staff exactly knew how to handle crisis. So this helps in your organizational growth and development at last. Secondly is it facilitates communication, and it also validates the selection techniques and human resource policies. So you exactly identify the individual who is going to fit for the job. You would just not put a trainee nurse, in a very critical environment when the nurse is, looking very lost in those kind of situations. You would want skilled hands. You would want nurses with upgraded knowledge and understanding to face that situation. So this helps you in your human resource policies. You will identify and draft those policies, what exactly, kind of competencies you would expect from the staff who is deputed in that particular area. Okay, the next is we look into the purposes of performance appraisal. It basically helps us to review the performance of an employee. It helps us to judge the gap between the actual and the desired performance. Here it is basically important is because we may have a lot of expectations from our staff at the same way how staff expects at the end of the year, there may be a hike in salary, or maybe I would get a promotion, or, I would be given additional responsibilities. So until and unless this has been clearly explained and documented what is expected of the staff, and you would not be in a position to check where do they stand when you sit for your performance appraisal discussions. So it's important that you portray in front of them what is the expectation, and then you measure those expectations with the actual performance. It also helps the management in exercising organizational control. So here you would understand that you will have your key players or you have your A players who are quite good at their work, or you will have managers who are quite good. And in case of crisis, you would be able to manage the situations when you have good people with you. It also helps us to formulate the training and development needs of the future. So you would, as a hospital, you would be expanding, you would be looking into new services, or you would be getting into the latest technology. And you would want staff to be, to be ready to face those challenges or to take up new responsibilities. So hence the need for training and development of the future. So provide information to assist HR decisions like, yes, promotions, your transfers, etc. It also gives clarity of the expectations and responsibilities of the functions to be performed by the employees, what we have just discussed, to judge the effectiveness of the other HR functions, that whatever HR policies you would have implemented into your organization, you would have planned various competencies for your staff. So what exactly has happened at the end of the year? Have your staff been able to cope up with those trainings? Have they mastered their skill sets? Is something that we have to look into. To reduce the grievance of the employees, this is a very common feature that we do see during performance appraisals when we have a one-to-one chat with your staff. Many things which are bottled up over the time, they would come and open up and say, I have faced this, this is what my problem comes in, and this is where my weakness is, or I have been facing this weakness over a period of time and I've not been able to overcome it. So once you exactly know, or you decide what is going to be the challenges, or you are going to decide what the staff is able to perform, the grievances of the staff will be reduced. It also helps to strengthen the relationship and communication between the superior and the subordinates, and the management and the employees. So what's the concept of performance appraisal? It should be in written, and it should be carried at least once a year. This is the basic, what you can say, basic forum what we will look into and we do a performance appraisal. You could also have a half-yearly performance appraisal, but it becomes a tedious task, in case if you have a huge number of staff with you. So once a year should be good enough. The performance appraisal information should be shared with the employee. This is very important. We cannot keep the employee in the dark and say, why your performance appraisal has been done and it has already been shared with the management, without the staff knowing exactly what is he or she been graded on, what are their strengths, what are the weaknesses identified, and what is the rating scale they have got at the end of the day. So employees should have the opportunity to respond in writing to the appraisal. That is, once you have discussed the appraisal findings with the employee, it should not just be kept verbal. As you are documenting the findings, you should also give a chance for your employee to document in writing back to you, to respond in writing, whether they accept what your findings are, or they accept what you have planned for them, or they accept the challenges that you have proposed. So it should just not be a verbal context. It should be very well drafted. The employee should have a mechanism to appeal the result of the performance appraisal. Someone feels that it has been unfair on them, or if there has been a bias in the performance appraisal system, then they should be given a chance, or you should have a mechanism in which they would appeal for the results, and a lot of clarity could be given to the employee based on your incident reports or your anecdotal reports, or whichever method you are following to keep a track on the staff. Managers should have adequate opportunity to observe the employees. This is also very important. You cannot grade a staff just if you have been a manager there for just some months, and you wouldn't have got a lot of time to interact with your staff, or you haven't got a strong hold on how your staff is managing your department. So you should have, the manager as a whole has to have a good opportunity. Next, you should have anecdotal notes on the employee's performance, and this should be kept during the entire evaluation period. And this is very much important, is because once your employee or your staff knows that you are tracking him or her, or their skill sets, or what they are able to do on the floors, and this is what is going to be the basis on which the performance appraisal is being done, then there are better chances that they will improve. They will, kind of take it in the positive way and try to upskill themselves. Or else, when you don't have a record with you, tomorrow they can manipulate or, say bad things about the way your performance appraisal is being done, or, bad mouth about the system wherein, it being unfair to them, or, things like that, creating a lot of chaos in the team. And at the end of the day, if there is no strength in the team, or there's no good teamwork because of so many disputes and wrong information, then your whole team collapses, and you may not be able to manage their department effectively. So a good noting or way wherein when you pen down the report, you also ask your employee to countersign it, so they exactly know what you have penned down is exactly what has happened, and you are being aware about it. Your evaluators should be trained to carry out the performance appraisal process. Even though you may have a performance appraisal in a form of a checklist wherein you have various parameters to be monitored, you need to have all the evaluators, it could be your managers, it could be your supervisors, who know exactly what that statement or that context means. So everyone should be on the same page when they are evaluating the staff. The performance appraisal should focus on your employee behavior. That's very important, rather than on the personal traits or characteristics. So you may have a habitual person, you may have a staff who's very good in her skill sets, but who is an habitual latecomer. Makes no difference to him or her whether they come on time, or because of them, the other staff members are delayed. These all things have to be kept in mind during a performance appraisal, irrespective of how good the team member is. So let's look at the performance appraisal process in brief. Basically, you need to have established performance standards. You need to exactly earmark or identify what are the standards which are going to be followed for your performance appraisal system. Next important thing is communicating these standards to your employees or to your staff members. Next, you have to have a measuring system. So you have to measure the actual performance. So it could be in the form of various ways, where there are various methods in measuring the performances of staff. So one should have the list or the checklist, or the ranking scale, or a 360 degrees performance appraisal system. So whichever system you have in place has to have give you some kind of a measure, rather than having a vague way of saying that, oh, this particular staff is excellent, that particular staff is good. So until and unless you have some kind of measure given to your system, you would not be able to clearly identify or defy your employees' performance. Next is comparing the actual with the desired performance. This is what we have already spoken. You will discuss the results with the employee, and finally you will make a decision. Next is the benefits of performance appraisal. Yes, first it is basically to assist or to enhance your employee performance. This is how, when we upskill, we train our staff, we identify their strengths, we give them a lot of appreciation for their work. So you build up on your, or you rather enhance your employee performance. Next is, it is integrated, it has to be rather integrated with the strategic vision of your company, of your organization. What are you looking at as a whole team, as a whole organization, and then what you expect your individual employees to contribute towards that goal. It can be like, if you have a good performance appraisal done, and you have employees who you really find are good at their workplace, so you would give them some kind of an appreciation, like maybe a hike in salary. You will compensate in some ways so that they stay with you. You are able to retain such a performance in your team. You would also look into kind of promotions and transfers. You find a young team member who's come in, who's very enthusiastic, and takes up additional responsibilities even without being given, and is a team player. You would always want to look up and say that, oh, I need this person. And in case there's one team which is already having those various positions in place, you would always want to facilitate this person in some other team and ensure that this person stays with you, and you have a good performer with you. And it is basically a tool of inspiration, because this is the tool wherein you basically do a SWOT analysis of your staff. You understand their strengths, you understand their weaknesses, you find out what are they going to be beneficial for, what trainings will be required, what are the other areas that you look into, and to try to improve them as an individual, so that you have good people with you on your team. Let's look at some of the limitations of performance appraisals. Sometimes some methods are unreliable, all right? So you may just have a checklist, or you may have a manager who will just kind of tick mark all the columns and say, oh, I have a good staff with me, or my staff is excellent. The employer may be biased, in case if you have some favorites on your team, and there could be, because it's a human behavior, you could be having some likability to your staff. So the employer could be biased in some cases. We may also have a case wherein the supervisor may be unable to appraise an employee, leading to inaccurate performance appraisal systems, or to maybe unable to give a clear picture about the performance of the staff. We also have situations wherein all qualities cannot be easily appraised through any appraisal methods. Sometimes someone may be appraised as good, to avoid any displeasure in the team. So, we may have some of our managers saying, all my staff are good. How are you going to, ensure that a good performance appraisal system is followed in that team? And uniform standards may not be followed during performance appraisal, and which may lead to false appraisals being done, and then you as a manager, if you are an organizational head, you will face up with various difficulties with your staff. Let's look at some of the components of a comprehensive appraisal system. Basically, it should determine the ability required. That is, you should have a job description in place. So whatever position the staff joins in, you have to have a clear job description, which makes it very evident for the staff to understand what are the expectations of his or her services. Next is match the abilities of the employee with the job requirements. That is, you can have personnel selection here. You will identify which person is fit for what kind of a job, in which team, in which area of service. Improve employees' abilities, that is, you check for staff development. And at the same time, you enhance the employees' motivation. So you will have some staff development activities being done in your organization. You'll have some way of rewarding the staff for a good performance. So you have a reward system in place. Qualities of a good appraisal. It is factual, that is, it is based on facts and not, kind of fake stories or kind of stories which are made by staff's discussion. So you have your facts and reports clear. It's fair. And it describes the whole period. That is, if you are having an appraisal system for the whole year, you actually come to know how the staff has performed throughout the year. And it describes the whole job. Basically, when we say it is based upon the job description, job responsibilities which have been given to your staff. So you understand where the staff actually stands because you have given the staff a clear guideline. This is what I'm going to look at, and this is how you have performed. And basically, it has no surprises because you make things very clear to them. You have a report which is drafted. You may have your anecdotal records in place wherein, you clearly make your staff understand this is what has been drafted about you. Once you have made your performance appraisal, you share it with them. You have a process wherein they can voice out their concerns. You have a process wherein they can appeal in case if they feel it's been unfair. You have your anecdotal records in place for a look back period to understand, on what grounds is this particular staff being graded. So it leaves absolutely no surprises to them. So there have been various methods of evaluation. We have some traditional methods and modern methods of evaluation. We'll not go much in detail here. And next is in order to have a correct job system, or in order to identify or hire the right people and give them in the right seats, Jim Collins says you also have to work to retain and engage these people once you have them. So it's not only having your employees on board, you need to have employees who are engaged, who are productive, who deliver results, and also who are excited about the future. So are you having a team of employees who have this with you? And this is something that we need to look on. So because it has been found that the best companies across the world use key performance indicators for their employees to drive their performance and to ensure that they're getting the most out of their most important investment, and that is their employees. So what's KPI, or what's a key performance indicator? It is basically a term used to measure or monitor the performance against an agreed goal. So a KPI is a way to measure employee performance in the workplace. So you are actually defining a number here, right? You are giving a numerical to understand, okay, this person's performance is 7 out of 10, or these are those areas which they have to work on, and this is the result that I'm getting at the end of the whole process. So let's look at this in detail. So why use KPIs for an employee evaluation? Because KPIs offer valuable insights, right? It delegates the tasks effectively. It enables to understand employees' strengths and weaknesses. Okay, it also portrays your employees' performance evaluation. It helps us to sort out team management issues, and it also assesses our payroll operations. So if you look at this pyramid, right, we have to understand how KPIs fit into an organizational structure. So KPIs link organizational vision to the individual action. So if you see, these are the various steps in the pyramid. We have the vision of the organization at the topmost. We have strategy, objectives. We have CSF, that's the critical success factors. We have KPIs, and we have actions at the bottom. So the pyramid has the strategic vision at the top, feeding down to specific actions at the bottom. So in the middle, you'll find the KPIs that have been derived from the strategy and objectives and critical success factors of your organization. So this CSFs, that's the critical success factors, are the areas of activity in which your organization must perform well in order to be successful. So KPIs are the means by which these CSFs or your critical success factors could be measured. So basically, if you look in, if I have a vision to be, an organization which is being known at international level or to be known at national level, I would follow certain standards. And now we have NABH with us. We have JCI who are accrediting bodies who have their standards in place. So to achieve those standards, you need to have key performance indicators from each department. So once, if you know, I have, as a department, I am able to achieve my standards through the key performance indicators, and I perform exceedingly well and ensure that, no harm has gone to my patient. I, as an organization, will be able to maintain up those standards and get accredited. All right. And the whole process continues as a whole. Now, how do we come up to individual key performance indicators? This is basically is when you know what are your critical success factors. Like for an organization, you may want zero needle prick injuries. As an organization, you may have all your infection control standards in place. You may have zero VAPs. You may have a minimum amount of COAHS with you. You may have few numbers in your pressure injuries. So you basically look into these aspects or these indicators which are defined by these accrediting bodies. You, as an organization, put up various policies and procedures in place to, obtain those standards. And once you have obtained the standards, then you come to your accreditation. So just not the department per se who has to follow these policies and procedures. It just boils down to the lowermost grid, and that is your employee who is at the bottom, who is actually working at the bedside, who has to follow all the policies and procedures to ensure that your standards or your key performance indicators are achieved. This is at an organization level. So when you come down to the employee, until unless you explain or you communicate your strategy, you communicate your vision, you communicate to them, this is what we need to achieve. And these are various interventions which are in place that you need to follow at the bedside so that we achieve this at the center is very, very vital. So unless these action plans are in place, your key performance indicators are not identified, and you do not have your critical success factors mentioned, you cannot achieve. You may have rather a big gap in those areas. Your vision will be it becomes a very difficult thing to achieve your vision. So as you come down from your vision to actions, everything is interlinked, it's co-linked. So you or the organization cannot say that, well, I have just my policies and SOPs in place, and I don't have a way to audit my policies. I don't have somebody monitoring at the bedside. I don't have trainings happening for my staff for varied reasons. And, I don't have a good team with me. It will be a very difficult task to obtain that vision. So how do we formulate KPIs? So we at the previous slide that we looked in, this is just some examples, statements wherein how KPIs are formulated and how data to be collected. So CTQs are again the same, the critical to quality values, or CSF, as we know, is the critical success factors. So if I want to state that all repairs to be done within 5 days, or maybe I have some kind of my biomedical department looking in, and they said I will ensure that all syringe pumps are repaired within 5 days. My key performance indicators for that department will be the percentage of repairs done within 5 days. Here I'm in this first thing I'm saying all repairs. So I don't know whether I have 100 equipments, I have 50 equipments to be repaired, but my key performance indicators will clearly define or will tell me what is the percentage of repairs which is done within 5 days. And the data to be collected will be time to complete each repair. So if I know maybe the engineer takes around 2 hours to complete one task, or to complete one equipment. So with that, I will be able to understand what will be the exact time that is required. And based upon this, I will be able to identify what is the percentage of the work done by that particular employee. So another example is I may have, on time in full delivery. Maybe you have some kind of a system wherein you want the delivery to be done on time and in complete. So again, your KPI would be the percentage of on time or in full deliveries and the time and quantity delivered. Okay, so here again, the next example will be like if you have a call center, the call answered within 5 rings, right? And again, you will monitor the percentage of calls which are answered within 5 rings. And here your data would be the time to each call. So we have TATs for various labs. We have TATs for radiology procedures. So, this is something where you can co-link and identify the kind of KPIs that you can have for that department. Another important thing is setting smart KPIs. Now, the word smart, if you say, whatever KPIs you would formulate for your organization, you need to understand that it has to be smart. So the SMART acronym stands for S being specific. You need to be very clear about what each KPI will measure and why it's important. It should be measurable. That is, the KPI must be measured to a defined standard. That's what we just talked about. Thirdly, it should be achievable. You must be able to deliver on the KPI. Just formulating a KPI and keeping it aside makes no sense. So unless and until you have to be specific, you have got measures in place, you have to have KPIs that are constructed in such a way that they are achievable. Next is you have to be relevant. That is, your KPIs must measure something that matters and improves performance. Like in a clinical setting, you can measure so many things, but you have to have them as relevance. Like every time I check on my key performance indicators in a department and I find it only zeros, and I have to think twice and understand, do I really need to measure this, or is there something which is at fault because I'm not getting the data clearly? And maybe there's some lag in the data collection or some lag in which some things have been faulted and I don't get an accurate data. Importantly, it should be time bound. It's achievable within an agreed time frame. And another thing is how to set individual KPIs. So what we were just talking about is your department KPIs. Now we'll just talk about how do we set individual KPIs. So one thing very clearly we have to remember is what gets measured gets done, right? So when you set goals and KPIs with individual team members, make sure that they align with your team's overall strategy, which in turn aligns with the overall strategy of your organization. Very simple example we can take is, at the end of the day, we should have 0 needle stick injuries, right? So as a department or as an organization, you are practicing safe patient care. So when you say I have safe patient care, I have 0 needle stick injuries for my departmental goal, I have to ensure that certain interventions which I have put in place, like no recapping, I should have my needle cutter or the thing is in place. My staff knows when they are going to give medication that thing has to be disposed at source, not come to some other place and dispose things. So you have your interventions in place. So you have set goals for your individual team members to ensure that whatever process that they do, they have a finite way of measurement. So you have somebody who's monitoring who says, all right, or you have your infection control nurse who comes for us and she says, I have seen your staff who is dealing with medicines, and their way of operations is very appreciable because they follow all those interventions in place. And at the end of the month, when you see, you find there are no needle stick injuries in your department. So next is defining an employee's goal with an organizational KPIs ensures that their daily activities are well aligned with the goals of the organization. And this is a critical link between the employee performance and organizational success. So basically, when you say this is, as what we had seen in the pyramid, this is my organizational goal of patient safety, and I ensure that each of my employees know what is expected out of them. You define their employees, you define their goals, and you link them. See, the moment I have these all things or interventions in place, I will be able to achieve this plan, what we have, or this vision for our organization. So this has to be clearly communicated with your employee, and how you define their KPI also matters in this regard. So let's look at this KPI creation flow. So at the same pyramid, what we had seen initially, here we have certain things, that is, you have your company vision, and it all boils down to individual operational KPI. So you have your company vision, you have your strategic objective in place, you have your organizational KPIs, the team operational KPIs, and the individual operational KPIs. So using KPI as an example, if you just want to see, like, if your organizational vision is to be known for high customer satisfaction and superior service, this is your vision. Your objective is to reduce the number of dissatisfied customers by 25%. So you are quantifying it, you are giving it a number, and you're exactly stating, this is what I want to achieve. So it is factual. You exactly know what numbers are you looking at, and you know what your problem is. You know how big your problem is. So you want to cut short on that problem. Next is your organizational KPI. So this is for the organization as such, the number of customer complaints that remain unresolved at the end of the week. So your main objective is to ensure that you have satisfied customers. But at the same time, you are monitoring your team on a weekly basis to understand how many complaints went unresolved, even though your team is working on it. So the organization is, working with the team at the ground level. So they are getting a feedback, or weekly feedback on how things are progressing or how things are working. The team members' goal is to increase the number of satisfactory complaint resolution by 15% in this period. So this is what is the team goal. And the member, each person's goal will be the weekly percentage difference in complaints handled that result in satisfied customers and against unsatisfied customers. So if you just look at this example, you have the organizational vision and the team members' key performance indicators completely linked. So you have the organization following it up after end of the week, and you also have the team members giving you a weekly percentage difference, a weekly data on how many complaints they were able to handle and handle that resulted in satisfied customers as well as unsatisfied customers. So this is something where you are interlinking your organizational goals and vision with the employees' key performance indicators. Right? So how do we create KPIs? Basically 5 steps. You establish an objective, and your second is you outline the criteria, collect data, build a KPI formula, or present your KPI. So when we say establish an objective, you clearly define the strategic objective or operational goals for the KPI to be measured. Outline the criteria. Here you identify the data that will be used for the KPI, because once you identify the data, you will exactly know what kind of data you need to collect. And once you collect the data, until unless you have a formula in place, how will you evaluate to understand whether you have achieved your objective or not? So you will need to build a KPI formula. And once you have done this process, then you need to present your KPIs. So this is presenting is basically to communicate to your or visually present your KPIs on dashboards or tools to suggest whether you have been able to achieve, or you are lacking as a team, or what other measures that you need to employ so as to say that you have achieved your targeted goals. So this is just one example of a key performance indicator of a nurse practitioner. So these are the various areas that have been indicated, and what are the expectations. So category of key performance indicator is patient care. So you expect nurse, midwife, whatever title you have, which is the department they are working. The key result area or intended outcome will be to decrease in morbidity. So your sample indicator will be symptom management of physical or discomfort or pain. So here you give them a target. You say, there should be a 10% increased improvement in symptom management of pain over 3 months. So you have defined some sample indicators, like you have physical assessment of patient, you have pain assessment using validated tool, you have appropriate intervention in place. At the same time, you have reassessment of pain within a time scale stated in local policy. So your at the end of the thing of all your interventions is you have to achieve a 10% increase improvement. So what's the metric? What is the data that you'll be looking here is your monthly audit. So you will do a 10% of patient charts, which will, which will give evidence on your physical assessment done by that particular nurse, pain assessment which has been done and which has been clearly documented in the patient's charts. So every month you will identify what status have I come in, what is the percentage of improvement that I have seen, or what is the target that I have achieved. And then finally you come to a conclusion whether this target is met, then you continue the audit as above. If target is not met, examine the reasons and address as required. Because until unless you don't clear out the bottlenecks, you will not be able to achieve your desired outcomes. So every time you have a particular person working on a particular project, you have a person working on certain KPIs that you have assigned for them, it's not mandatory that they will be 100% doing their things and everybody will be quite skilled or knowledgeable about how to go about their things. There would be some difficulties, there would be some hindrances. So until unless you ask for a feedback on what are their grievances per se, what are their best best points that they have worked on, what are the challenges they have faced, how they have overcome those, it will be very difficult to achieve the targets as such. Here next I have another example, but we'll not go through that much in detail. Let's look at how KPI reportings and KPI dashboards help us. So KPI reports are again recurring reports. They should include your KPIs to facilitate continual analysis. You would maybe have a monthly presentation, or you may analyze your staff performance on a monthly basis, or at the end of the month you will have these many indicators or these many medication errors, identify which staff was included and whether she was has done it intentionally, or whether there were some circumstances which were beyond her or his capacity which led to that error. So you also have KPI dashboards, wherein you have a graphic interface that displays KPIs, and also another important information which is populated with real-time data. So you could have, you can have dashboards that have been customized. We have softwares now wherein you just have to enter your data and your graphs or your data is clearly depicting your monthly performance or your yearly performance to your team. So this is something what a dashboard looks like. So here we have some emergency department outbound dashboard, which shows the kind of performance which is done by the team every month. And also it has some inpatients inbound. So you can have this kind of a dashboard prepared for your department or for your team, and individual ones you could probably keep a dashboard record on your system as if you are as manager and produce it at the time of performance appraisal and say this is where you stand, and which clearly indicates how the staff has performed over the period of a year or the time period that has been mentioned for performance appraisal. So KPIs for recognition and development, yes, it's important, as we had initially seen that everyone appreciates some kind of feedback. People look up for promotions, people look up for salary rise. So at the same time, we have to remember that what gets measured gets done, but what gets rewarded gets done too. So rewards are very important. So when you establish your rewards and recognition practices, make sure that they relate directly to the KPIs you have set and that you are not rewarding potentially counterproductive behaviors. So your rewards should be earmarked with the KPIs that have been achieved. In case if that individual is able to achieve the set KPIs, you have to define what is going to be a reward. Maybe there will be a salary hike, or a kind of a promotion to the team, or felicitation in front of the whole team. That's something as a organization you have to decide for your staff. So what are some of the disadvantages of KPIs? Basically, it's a misuse or gaming KPIs. So you may find some examples I'm giving is you may find a call center where employees are calling each other just to keep their number of calls indicator in the green zone. So, this is kind of bluffing the system. You may also find surgeons who don't take difficult cases that might affect their public rating. And you may also have cases where police officers who are downgrading crime classification. So you have various examples wherein, people misuse KPIs for their own benefit. And this has led to companies' downfall, then that's where we come to know that scams have happened in various organizations. And it has been in the highlight after 4 or 5 years, you have wrong data which gets published and so on and so forth. So again, why do these KPI failures like this happen? Because some cases happen because of the bad side of human nature, all right? And we should not, by majority of cases, we need to blame the management directly, because sometimes there's so much of pressure on an individual to perform. You push employees too hard towards working on their KPIs, and your KPI just itself becomes a target for them. You may link incentives to the KPIs and you don't validate them later. And you invent KPIs on the top and mandating them to the bottom, that is you are and top management, wherein you decide this is what we want to achieve, and it doesn't percolate down to the employee at the lower grid, and no one knows what is being expected out of them. And we kind of skip the discussion phase or the communication phase between the employees and the employer. You may set the target value for an indicator, but you do not discuss an action plan. So in the previous slides, we have actually seen in case if I plan for a KPI, what is going to be my action plan? If it fails, what do I do? And if it is successful, okay, well ahead, go ahead with those things. So you have to also discuss the action plan with your team. And mainly we always focus on the destination. We say, this is what we want to achieve. This is where we want to be. We may be the #1 company in the whole country or so on and so forth. But we sometimes forget about the quality and the value aspect. What kind of quality are we giving into, our or the kind of services that we are being provided in the pursuit of excellence. So what are the solutions for misuse? We have two kinds of solutions. One is a technical solution and one is a cultural solution. Technical solution, it's very simple. You use performance value or performance quality pair. That is, you pair up the performance indicator and the quality or value indicator. So unless you don't have the performance indicator in place, and you don't identify what is the quality value indicator you are applying to it, you will not be in a possible solution. You may not be in a good way to find a solution for your problem. Second is a cultural solution. Here it is more about discussing and learning. So once you identify that your staff is having some difficulties, ensure that it has been discussed, their weaknesses have been discussed, the good things that they have done, how far they have progressed is being worked on. And once you have a healthy discussion with your employee, you will be able to understand that they are able to give in a productive work. Their stress levels are decreased and they are, kind of ready to work further or, improve their performance. So before I close, there are some SMART goals for nurses that they can always look into for further performance and, for the improvement in your profession. So importantly is you need to further your career. You may go for higher studies or take up some courses to ensure that your knowledge and skill is upgraded. You can earn certifications. It's very, very important that you do certificate programs to, add into your professional value, grow your nursing knowledge, participate in the clinical ladder program that, you may have additional courses done so you can move on from a team leader to a shift supervisor to your manager and things like that. Important is connect with your team. So make friends, go out, talk to people other than just work and talk to your friends. And importantly is work on your weaknesses, because until you make your strength, you identify your weaknesses, you cannot convert them into your strengths. So with that, I end the session. Thank you for patient listening. I'll be open to any questions if any of the participants have.
Thank you, ma'am. Thank you, ma'am, for the remarkable session. Now, let's move on to the final segment of the day, a panel discussion on the topic assertiveness and leadership for nurse executives. We have a panel of 4 experts, and the discussion is to be moderated by one of the prominent nurse leaders, Dr. Anis George. I invite Dr. Shajila CH to introduce Dr. Anis George.
Good afternoon and welcome to the panel discussion. Indeed, I am privileged to read the CV of an eminent nurse leader, Dr. Anis George, who is currently working as a professor at Manipal College of Nursing. She is a nurse educator, administrator, and researcher, and a registered nurse who values caring as the fundamental core of the nursing profession. Dr. Anis George has completed Bachelor of Science in Nursing and Master of Science in Nursing from College of Nursing, CMC, Vellore, then a Master of Philosophy in Nursing from RK College of Nursing, New Delhi, and Doctor of Philosophy in Nursing from Mahi, Manipal. And she has joined the Manipal group in 1991, initially as Vice Principal and later worked as Dean till July 2021 of College of Nursing. And Madam has formerly served as the Assistant Dean for pre
Good afternoon to everyone. Are you able to hear me?
Yes, ma'am.
Yes, ma'am. Because for some time what Shajila was talking, I was unable to hear. So I was thinking maybe net problem from my side. I hope Shajila has finished. A very pleasant afternoon to all of you. Thank you, Shajila, for that introduction about me. I don't know so much of introduction whether I deserve or not, but thank you so much. I congratulate the College of Nursing, MIMS, Calicut for organizing this national conference on healthcare management strategies and tools for evolving healthcare executives. My relationship with MIMS and with Asuma is a long-standing relationship, and later with Dr. Shajila while doing her PhD here. So it's I consider it as a pleasant privilege to moderate the panel discussion on the topic assertiveness and leadership for nurse executives. I would like to welcome all those who are joined with us online to attend this panel discussion on an important topic, which I am sure that more than we, the senior people, the youngsters are looking forward to listen to, because they have a long way to go forward and they need to listen to this. I welcome and wish all the best to my team of panel members, Dr. Sudha Reddy, Dr. Larissa, and Dr. Prabha Dasila. All three of them are leading nurse executives primarily focused in the nursing academia. So I'm sure that the youngsters who are looking forward to listen to them will be very happy to listen to the speakers. We have bifurcated the major topic into 3 sub-areas like techniques of assertiveness. Dr. Sudha will be talking to us on that, and assertive communication and its benefits by Dr. Larissa. and how assertive nurses are in their workplace by Dr. Prabha. Without taking much time to talk to you all now, I take my responsibility of introducing. First, I will introduce the first speaker, and after that, as each of the speakers' turn comes, I will introduce them. The first speaker is Dr. Sudha Reddy. She did her UG and PG in nursing. UG from College of Nursing, FMC Pune, PG from KLE Belgavi, Master of Philosophy from MCon Manipal University, and her terminal degree, the PhD Nursing from National Consortium for PhD from RGUHS and Indian Nursing Council in the year 2014. A very active member of SOMI chapter in the country and especially in the southern part of our country. She's a nominated member of Standing Regulation Committee of International Confederation of Midwives for Southeast Asia. She has participated as a SOMI leader in exposure visit to Sweden, and she's part of a number of UGC, NAC, and Indian Nursing Council team visits for evaluation of universities. A master trainer for virtual capacity building program for midwifery faculty recently, which is being organized by Indian Nursing Council and UNPFA, and also a master trainer for Helping Babies Breathe program. She has wide exposure internationally as speaker and as experts in her areas of speciality. She's a principal investigator for UKD project between University of East Anglia, Norwich, UK, and KLE University, Belgavi, and visited UK twice in 2014 and 15 respectively. Principal investigator for funded project on mental health for postpartum mothers with Thomas Jefferson University, Philadelphia, and Southern Cross University, Australia, for developing a M-learning app for UG students and communication skill in management of chronic disease. Dr. Sudha has organized many international and national conferences and workshops. She has a total of 27 international publications and 17 national publications. A member of academic bodies like Board of Studies, Academic Senate, PhD committees, and she's a PhD guide and examiner. She manages in her organization the dual role at hospital and nursing college. And she's also an advocacy committee member in the Association of Nurse Executives, India. With these few words, I would like to introduce Dr. Sudha Reddy and welcome Dr. Sudha to talk to us on techniques of assertiveness. To you, Dr. Sudha.
Thank you so much, Anis ma'am. It's such a wonderful platform here today. So much of connections with Manipal. A very warm thanks to Dr. Asuma Baby ma'am, Director of MIMS Astra Academy, and also the Principal of the College of Nursing ma'am. You were my MPhil examiner, Asima ma'am, and there I have the whole guru in front of me, Dr. Anis, such a role model, former dean, figure of simplicity, humbleness, and so much of intelligence, especially emotional intelligence, should learn from ma'am. And then I have my very close colleagues, Larissa and Prabha Desella. I don't know who is closer to me. I think we have been working together, and I thank Shailaja ma'am and Dr. Asima and her team to let us all meet in this platform today. And have you allowed me to share the screen? Shailaja, I take this opportunity that I'm going to rope you in for my next Department of Nursing Education workshop on AI in nursing. I saw your name somewhere as a resource person, so I'm going to not leave you, Dr. Shailaja. With this, thank you, Anis ma'am, for introducing me and whatever I am today. And because of AFMC Pune, KLE, and Manipal, so I'm an alumni of these three institutions. Thank you so much. I'll try to do justice with the topic. And I really enjoyed what Dr. Savia was talking in the last session. And it is so impressive that Dr. Savia is the nursing superintendent of MGM, and how beautifully she's mentioned as all the clinical application of the performance appraisal and how we do it. So thank you, Dr. Savia. And a wonderful platform. Without wasting much time, I start. the topic which is given, as ma'am said, is assertiveness. I have purposely not put here leadership and communication, because when you put the term leadership and communication with assertiveness, all the junior faculty, students, teachers will think, oh, this is only meant for the leaders, not for us. But each one of us is a leader, right from a first year student. And let's see what is it we are going to talk about assertiveness today. You know, many times we all have to deal with difficult situations in our workplace or even in our family. We have co-sisters who, like, they don't listen to us, or they feel they are much better housewives than us. And if you see in the workplace, you have teachers who have, you know, cold wars going on. We have to pacify them. In the clinical side, we have the doctors. We have to, you know, ascertain what we really want to do about the patient care. So this situation is everywhere. Lot of conflicts in mind always occur between people, and everyone views the same situation from a different point of view. From person to person, it varies. All of us are humans. We all have emotions and egos, and when something like this happens, it bothers all of us. So, you know, we have to be the passive. People are either passive, they listen, they, you know, undergo all the things passively, and some are very aggressive, they come out, fight, unpleasant situations, and some are assertive. So all of us need to be assertive. It's a very beautiful way to deal with life, with your profession, with your family, with your patients especially. So what are these difficult situations which all of us can face? We will have, you know, you are punished by your supervisor for something bad you have done, or sometimes not done. I remember when Dr. Suresh Saleh sir was there, a very eminent leader of the past. One of my students had taken out a sterile gauze pad, and she had removed it to clean the surface. So wasting a autoclaved sterile pad to clean the surface, and he came and he shouted at me, what kind of a clinical instructor you are? Can't you see how your students are wasting things? So sometimes you're scolded for not doing things, or sometimes you really have done something. I've broken an important, you know, methotrexate ampule, and I had to pay for it sometimes. So this happens. Then you're driven crazy by patients. There are patients, you know, in the emergency and trauma, who are shouting, who is an alcoholic, who has come. You all are running around trying to manage him. He's abusing all of us. Scolded by your boss for sleeping at work. It happens sometimes. But in meetings, so I really sometimes, you know, when there are afternoon meetings, you really sometimes have to really look, someone has to shake you up. Then disappointed by someone who really whom you really trust. This happens with many of us. We say how much we trusted ma'am, but this happened. You know, you have to listen to the teachers, your clerical staff, sometimes the patients. People ever plotted against you? So these are all difficult situations which all of us face. You know, when you face a situation like this, I usually call my mentors across the country. It is either Jaya Kudwila madam, it is either Elizabeth John ma'am, Shushila Sai ma'am, or sometimes even President sir, do you feel that I can be like this? What is this happening? Then they tell me, Usha Banerjee, my mentor, my senior from FMC, she's a director of Polo Group. Then I said, do you feel I can do something like this? I've been a child in your arms and have grown up. Is it so? Then they tell, no, all nurse leaders at some time face such challenges. So bear with us, you know. So this is how we all have difficult situations. Sometimes colleagues ever gossiped and talked bad about you. They have ever wanted to say to you something you have been asked to do. So these are the things, you know, which we all need to face. And we all face. So it's time to think positively and look for solution, and seek a possible option, and take a course of action which can lead to better solutions. Or assertiveness. So assertiveness training is very important. I would just like to share that our project with Southern Cross University, Australia, was implementation of leadership and communication skills in management of chronic diseases among the third year undergraduate students. So they feel that around the globe, and especially in the Southeast Asian countries, the nurses are not assertive. They lack assertiveness in general, and we need to strengthen this. So that was the whole thing, where they had this learning app, and there were different modules on it. So that is what is assertiveness has been given so much of importance, so much so that the funding agencies are looking for funding for any one of us who can develop some kind of proposals in this field. So with this, I come to the just a simple definition of assertive behavior. So assertive behavior is a behavior which enables a person to act in their own best interest without undue anxiety, to express their honest feelings comfortably, and to stand up for their own rights without denying the rights of others. So all the things which are in red, purple, and blue are so important. Like, if you don't show anxiety, we stand up for our own rights, but we do not interfere with others' rights, is what is the main crux of the assertive behavior. And why to be assertive? Like, why should we be assertive? Because it increases, first of all, for us our own self-esteem. It reduces the anxiety and stress. It becomes you become a better manager, and it's a win-win situation for everyone, and you earn the respect of other people. And assertiveness is not what you do, it is what you are, who you are, you know. Like, if you want to go and face your superior and tell, I haven't done this and this, and if you're anxious and you have stress, you will not be able to deliver the message to them confidently. So you need to reduce this. You need to earn the respect of others. You need to be a better manager. So assertiveness is the mantra for all these things. And then what are the non-assertive behaviors? Like, if you're passive, very passive individuals who are not bothered, not committed to their own rights, and they are more likely to allow others to encroach on their rights than to stand up and speak out. So we have many of such people around us. If you just attend this presentation in a very qualitative manner, in the sense you try to think, what am I, what is my colleague, you will see all these characters around you. So they are not bothered only whatever is happening. So if you have a scale of assertiveness, you have passive people, you have very aggressive people, and the assertive smiley person is the one who is in between. And being aggressive means what? Like, you're likely to disregard the right of others. You want everything for yourself. You feel powerful when you dominate others, but later gives you remorse as people, go away from you. And then you tend to dismiss or ignore the feelings, needs, and opinions. And you tend to blame others for problems instead of offering solutions. ठीक है ना, जो भी कोई problem होगा, you'll try to blame others. Sometimes my son tells me, Mama, if this is not done, you try to blame me. If I have not done it, you try to blame Kupoma. Kupoma works for me. So why do you blame us? No, why can't you do it yourself? He tries to tell me. So all of us have somewhere one of the passive components, one of the aggressive components, which we all should positively identify and try to be assertive. So what are the tips and techniques in assertiveness? We will study about all of them. Like, one is a very commonly used phrase in administrative circles, the broken record, then using of I statements instead of you statements, use assertiveness, body languages. Like, if you're assertive, you should have a very strong body language, the delicate art of saying no, and use the DESO technique. I'll be elaborating on each one of them. And negative assertion, negative inquiry, and fogging. Fogging is another very commonly used terminology. So what is this broken record? You keep repeating the same thing. You select one short sentence of refusal and use it no matter what the other person says or does. And after each statement by the other person, you say your broken record sentence. Say it in a very soft, calm, unemotional voice. Don't attend to the other person very well. It will only encourage him or her to keep talking, and lot of silence. Allow plenty of silence and persist. You must say your broken record one more time than the other person makes his request. It usually happens, you have some staff who come to you, they want leave, both in the hospital and these settings, both the sides, I have to face these problems. Some of them will be doing distance education, PCBSCs, and they all will come together in a group of 30, 40 people for taking leaves because they have to go and give their exam somewhere. Same way, some teacher wants to go on leave when the NAC inspection is near you, approaching. Then you have to keep trying to tell them, see, it's not in my hand. I cannot give you leave during this time. You can go before this or after that. Please try to understand. Keep repeating in a very soft, calm, unemotional voice. Because say you feel pity and you send them, and then you have to face all the things by your higher authorities. So this kind of situation is a broken report. You keep repeating the person before he comes to you again. Before that only you tell, see, it's not. So this is one technique of assertiveness which you really need to use for some very persistent people who don't listen. And then you have the importance of I statements, means what confronted with an intolerable situation, being assertive involves 5 stages. Like first you always think, ki kya tha? What was it? Like describe the behavior. When you do this, I don't like. Express your feelings. I feel little less trust on you because every time you keep repeating this. There are some staff, as Dr. Savia also was telling, they come late and they don't, like, everyone doesn't feel. There are some people who come late, they are on leave, they are not present, and the college runs, you don't feel, ki, theek hai, she's not coming, doesn't matter my work in any way. But any 1 or 2 juniors would work with you, they don't come, you're like fully, you can't do anything, you can't move your things because those kids are not there. So express your feelings, like I feel this, empathize, I understand why you didn't come, you had everyone affected with COVID in your family, I understand that. Then negotiate a change. I want you to take up this responsibility and can you hand it over to the other person so that you are also less stressed, you can work and we will also manage. Every time you coming in front of me and every time we having an unpleasant conversation. So this kind of things, and indicate the consequences. See, if you do or if you don't do, then I will have to report to the superiors because the college can't run like this. We have to work. So let us both together solve it out. But in all the cases, not all the 5 steps may be required by you. And assertive body postures means you walk steadily, hold your back straight and your head up, relax your shoulders and spread your weight evenly on both legs. This really helps. You want to go and meet your nursing superintendent because you want leave for something, you want to change a ward, you want to get into a ICU because you have worked enough now in the general credit ward for a long time. Be assertive. The way you go, walk, talk to her and tell, I've done this, I've done that. She will say, oh, this staff looks good. I think I can talk to the in charge and shift her there. So तुम डरते मरते एकदम in a very low voice you go stand in front of her room, wait, and then you ask, nobody will give much attention to it. So these are very tricky things. Positive things, body posture is very important, eye contact, facial expressions. Our nurses are so good, our clinical nurses are so good, they multitask, they do everything. But when I have my students who come from UK, US, Australia, when they come on vacations here, I arrange guest lectures, they go and talk to the doctors, the MD, they're so damn confident and they sit there like colleagues and talk to them. They go to receive them in airports when the MD or the chairman visits UK or Ireland. All these 4 or 5 boys, girls who are just UG staff nurses there, they go talk to them. But same you compare here, when some of the nurses are so passive, they do so much, they are more skilled than me and you as academic person, but they don't have that confidence. That is why it is very important to teach assertiveness, leadership and communication skills to the staff nurses, to the undergraduate students, so that they groom with it. Maintain eye contact, appear interested and alert but not angry, and avoid looking away for long periods. These are some of the tricks. And you should allow enough room to feel at ease and move. You don't have to be scared. Why are you scared of anyone? You are a human being. Your parents have brought you up, spent money, graduated you, you're working. Why should you're working honestly. Why should you be scared of anyone? So these small little things, shifting your weight, moving around will ease the stress and anxiety, because people may tell you so many things. Oh, that matron is very strict. She won't listen to you. That floor supervisor is like this. So don't believe those things. Your honest work and your self-confidence and assertiveness will take you a long way. Sit or stand directly in front of them. Sometimes when, I'm not confident, like in the management meetings, when we all want to talk for increasing the salaries, I will know that my college budget is surplus, but not as much as the medical, dental, or other colleges, but still I'm fighting for a hike in salary for my staff. So that time what I do, I just try to stand behind the dental college representative and she tells, what is this, Sudha Reddy? You're standing behind me, come and stand next to me. But I know my tension. They will tell, oh, tumhara itna kam hai, and you're asking. So this naturally happens if we have less confident or we have some resources lesser to us. It is a very natural reaction, but we must try to control it. Be sure to be near enough to be heard clearly. without shouting. Have a nice modulation of voice. Some teachers are very good in teaching, but they whisper. We get a lot of feedbacks. We can't understand their classes. So these are the hints which you need to have. The voice, tone, and pitch. Strike a balance between whispers and very loud noises, and speak slowly, audibly, clearly, and calmly. Breathe normally to avoid nervousness. All these things really help. And then there's another very important skill which you need to have, that is listening. You should listen intently and attentively to other people and very respectfully, And we teach this when we do those INC classes where the adolescents come to you for some reproductive and sexual health problem. And if you are a staff nurse in the PHC or subcenter, they come and sit in front of you because they have this very important sexual problem. They are unwed, they have live-in relation, the girl suspected to be pregnant, they both come to you, they want to pour their heart out to you, but you are busy looking at your mobile messages, reading the newspaper, chatting to someone. So listening is a skill. Please listen. They come to us because we are in a position where they can express and they can seek some help from us. And external experiences also matter. Assertiveness can be expressed via your external appearance. So I always tell my nurses, dress up properly, be neat and smart, even in your uniforms, your aprons, everything, and don't wear a lot of jewelry and those threads around you, how religious you may be. Look neat, clean, smart, and otherwise even in your muftis, look smart and nice, because we spend money on you. Don't save all the money for your husband and children, because assertiveness is a part of the way you groom. And we should learn to say no. Many of us are expert in this. Many of us can't say no. But when you say no, it is important to be direct, concise, and to the point. You may offer reasons for your refusal, but then don't get carried away with numerous excuses. Always begin your answer with the word no. Ma'am, I won't leave, but during NAC, I will not be here. So just say no. Then make your answer short and to the point. The other day in the nursing superintendent's office, they have put one big sign only. Please do not come with request of change of wards. People are fed up, like all the juniors who are joining now are not like us. They all want, if they are very tired in some particular wards, they feel like changing it. So every time there's a big queue there, we have to sort it out and be honest, direct, and firm. This is DSO. I told you about DSO. It is making a request. So what does D mean? Describing the situation. E means express how you're feeling. S means specify what you would like to happen. And O is the outcome. So this is an easy way to ease out the problem. Like describe the situation. The deadline for presenting the data is tomorrow. But express how you're feeling. I'm concerned that I haven't seen your results yet. Or specify what you would like to happen. Can you send me your results by 3 o'clock? Outcome, then we can be sure of getting the data collated in time. See, this happens to us all the time. So we have to present the mock NAC presentation in front of VC. Then, I need to get the data from everyone in time so that I can sit with 2 staff who are good in slides, good slide preparation. I don't know to do that technology of making those nice, attractive animations, all that. Sit with them, get their time, do it, see the corrections. So all this needs time. So same way, anything, any decision needs time. So this is a nice way of doing it. Then sometimes you have to use negative assertion. This technique involves not only accepting the criticism, but also openly agreeing with the criticism as well as coping with your errors. This skill involves calmly agreeing with the criticism of your negative qualities and not apologizing or letting yourself feel demolished. Sometimes you keep telling, sorry, I'm very sorry, I didn't. No, you just accept it calmly and say, yes, I have done it. But don't stoop so down that, then people will this. And this always happens. No, I like those juniors who just walk into my room, and when I tell them this has to be done, and they tell me, no, ma'am, please, how can we repeat it? You're asking us to enter this in the mentorship online data also. You want to make a mentorship register also, notes also. It's all duplication of work, ma'am. And work diaries also, like you have given us a new diary now, but we have been writing this way. How can we repeat it? Can we start it from the next one? Then I say, yes, yeah, really. Then I said, sorry, I never thought. I like such people who come, confront, They may be junior to you and they say, and there are some people who are very goody to you, but then they go and, talk out. So that kind of thing, before that you learn to do negative assertion and accept of a faults, and take it in a very, theek hai yaar, galti ho gayi. So many things you're overseeing, somewhere you may miss something, it's fine. Like I gave you the example, like you'll find that difficult, won't you? Because you're shy. The reply will be, in what ways do you think I'm shy? I may be shy, but I may not be shy to ask for, I have 2 publications and I'm applying for increment. I'm not shy for that. I may be shy for something else. So you should know how to answer for that. Sometimes negative inquiry consists of requesting further, more specific criticism. And if someone criticizes you, but you're not sure if the criticism is valid or constructive, then you can ask for more details. Like you find it difficult, won't you? Because you're shy. Then again, in what way do you think I'm shy? So this is the most interesting thing, like fogging. Fogging is a technique. Like now in COVID, we had brain fogging, but this is not that. But fogging, the fog technique is only used when you're being repeatedly nagged. Sometimes you're being nagged. You may be the leader, but people nag you because they want something to be done. Do not deny any criticism and do not counterattack with criticism of your own. Accept manipulative criticism by calmly acknowledging to your critic the probability that there may be some truth in what he or she says, yet allows you to remain in your own judgment of what you can do. So this is a very important technique. Like you're over 15 minutes late for our meeting, delivered with aggression. Then, or you say, you're right, I'm running late and I can see that this is frustrating. So that is the way you, there are 3 types of fogging actually. You agree in part, you agree in probability, and you agree in principle. So what do you agree in part? Like example, the criticism, you haven't got a job, you're completely unproductive. Then you say, yes, it's true, I don't have a job. It's true, I don't have a job. So this is agreeing in part, but you're not telling that unproductive. Jab job hi nahi hai to unproductive hoga, but you're not accepting it. So you agree in part, yes, it's true, I don't have a job. Agreeing in probability, like if you don't floss your teeth, you will get gum disease and be sorry for it for the rest of your life. But the response, you're right, I may get gum disease. So that is more of, and if you agree in principle, the criticism which will come to you will be, that's a wrong tool for the job. A chisel like that will slip and mess up the wood. You ought to have a gauze instead. But the response will be, you're right. If the chisel slips, it will really mess up the wood. Same way in the hospital situations, when you're starting a IV and you're not able to see it properly, and that superior comes and starts telling you don't know, last time also you prayed, you don't know to do. So you talk to them in a proper way and see that, yes, in principle, yes, I had done that, I agree. But now I've practiced it. And I know that I have done few, in other words, and right, I will do. And if it doesn't happen, I will mess up, but I will try to be perfect. So these are some of the things for assertiveness, because only 20 minutes was given. So what I want to say, these are the techniques of assertiveness. Assertiveness is a skill. Assertiveness, leadership, and communications go hand in hand. I remember that when the Nirmala Sitaram has given out the budget now, and everybody's remarks are there. So in all national nursing groups, Dr. Roy George's remarks are there, how he has given his, representing all of us so wonderfully. He has given his comments on the budget. So this is how we are assertive. We show that we know, we are knowledgeable and in part of the system. So thank you so much. Hope some of the points which I have not covered, my other panelists will cover. And in the end, we can take up questions. Thank you.
Thank you, Dr. Sudha, for enlightening us on an important area in assertiveness. That is definition, differentiating assertiveness and aggressiveness, assertive body postures, and finally on fogging in detail. Thank you so much. I will move on to the second speaker of the panel, Dr. Larissa Martha Sanz. She completed her graduation from Father Mullah's College of Nursing, Mangalore, and Masters and Master of Philosophy from Manipal College of Nursing, Mahe, and PhD from Vinayaga Missions University, Salem. 22 years of experience she has after the Masters in Nursing. And Dr. Larissa has taken up a number of additional responsibilities. And to mention them, mention a few. She's a member of the 6 nursing organizations, and Dr. Larissa is the postgraduate Board of Studies chairperson at the largest health science university, RGUHS, since 2021. And she had been and is a member of Board of Studies Nursing at many universities. She's in the editorial board in a number of journals, has won many awards and prizes for her research presentations. She secured first position in research in her MPhil, and she's a guide for PhD nursing at RGUHS and examiner for UG, PG, and PhD examinations in many universities in our country. She has given around 60 talks and invited resource person, has published 45 articles in both national and international journals. Currently, Dr. Larissa is the principal at Lakshmi Memorial College of Nursing, Mangalore. I welcome Dr. Larissa to talk to us on assertive communication and its benefits. Over to you, Dr. Larissa.
Thank you, madam, for the wonderful introduction. It's really great that I am part of these MIMS National Conferences 2022. And the topic that is assigned to me is assertiveness, communications, and its benefits. So as already Dr. Sudha has mentioned about what is assertiveness and what are the many techniques that could be adopted, some of the points may be overlapping. So in terms of communication, is it necessary that the nurses need to be assertive, whether we are educators, whether we are administrators, or whether we are at the clinicians as a bedside nurses or at any capacity? Is assertiveness necessary? As it's a way of communicating feelings, thoughts, and beliefs in an open and honest manner without violating the rights of others. As we all know, communication involves the other persons or other groups also. We need to see that whether our communication is effectively communicating what we want to others without making others feel at low or at hindering their opinions or things. So this assertive communication, which is seen as an integral part of the nurses. So how do we see these things? We really need to pay attention to assertive communication if you want to be an effective nurse leaders in whatever capacity it is. While addressing the power of being assertive, Dorian Virtual, he said that once you have a major success with assertiveness, it is always necessary that how we can be assertive. It is much healthier path than being a doormat. So that means we can always spend our energy being assertive than being a doormat to anyone. You gain respect for yourself, have more time for your priorities, and also develop authentic and healthier relationships. But being assertiveness, definitely it is not a piece of cake. As told by Dr. Sudha in many of our examples, we may many times have a confrontation. We may many times have a very unpleasant situations. Sometimes the no may always have a very negative impact on the other persons. So nevertheless, being assertiveness is necessary, even though it is very difficult in an administrative level or at a leader level, whatever capacity it is. It would help if you had a proper knowledge of it and a fair principle to be good at it. So here we are going to talk about how one can be assertive in their communication. As nurses move far away from our traditional subservient roles and perceived stereotypes, it is increasingly be recognized that nurse must behave in an assertive manner. It is not that nurse is always at the end of carrying out the orders or instructions or followers. We also need to be assertive and show that what we are capable of. It is because very vital for the nurse-patient communications, and it's suggested that its development also can aid the arrogance of the professions because it develops. When you say we are a professionals, we need to stand apart from others, not always be subservient to others. Maybe sometimes, yes, but not all the times. What are the 3 C's of assertive communication as nurses that we need to follow? One is confidence. We need to be very confident to handle the situations. Without confidence, definitely one cannot be assertive. Very necessary. We need to be clear. The message you have is clear and easy to understand. And we need to have a controlled in terms of delivering of information in a calm and controlled manner. We cannot allow our emotion to override when we are communicating. Whatever may be the provocation, whatever may be the scenarios, the sticky situation, we need to be in a calm and controlled way to show that the other person, here we are at controlled situation, not the other persons. Say no more often. The no doesn't mean that blunt no. We have different techniques, how effectively we can say no, because it's the first thing. It is not that somebody always asks and we say we need to say yes so that we can please others. Then we are not assertive. There are situations which we need to learn how effectively we can say no. So it is a very useful communication. And it's not always appropriate to be assertive in all situations, as its sudden usage may be perceived as an aggression by some people. Some people equate with aggression also. So we need to be very careful with which situation need to be assertive. So it's the ability to express a positive and negative feelings in an open and as well as honest and direct way. It always recognizes our opinions while still respecting the view of others also. So the other person should feel that while we are expressing, their views are also respected. Always we need to watch our tone. It needs to be relaxed. You should sound and feel calm. Not that you are in a very tense state or an agitated state. It also means that not showing hesitation or harshness through your voice. Keep it friendly and calm most of the time. And always need to be willing to discuss further until you find a solution. It's not that when you're a leader, you need to be assertive and what you say is final. No. Always, there is always difference of opinion. There is no harm in taking the opinion of others before coming to a conclusion or finding a solution. And it is always gives a respectful manner until the issue is resolved. Usually it may be in terms of asking some questions, getting an answers and listening, very important, and or getting creative and getting more options. So whatever it is worth your time. As in the end, both the parties feel good and no one ends up hurt most of the time. Sometimes, yes, whatever you do, we end up hurting the other person, or sometimes we ourselves may be hurt. But at the same time, the time that we spend for discussion before coming to a conclusion is always worthy to be mentioned. And characteristics, how we can be assertive during the communication. I think Dr. Sudha has already mentioned in terms of eye contact. We cannot evade our eyes or look the other way. The body posture, where we are firm and straight. The gestures that we need to adopt while having a communication. The facial expressions that we're communicating. Because I think many times people always judge us by our facial expression. They say, your tone was not good. Your face told something, but you talk something else. So definitely people will judge us with the gestures. The voice, that is a tone that we use, whether it be friendly or a relaxed manner, or is it in authoritative manner, those also will be communicated. The content, what we are communicating, it needs to be direct and respectful. No use of beating around the bush. And pay attention to non-verbal communications. That is always I mentioned in terms of the eye contact, postures, the listening cues, very important. And the reactions, what reaction you give when somebody else talks. All this should be done without any sense of aggression or even passiveness, that you are not interested or you are overtly aggressive. What you need to be heard by the other person. Keeping an eye contact that needs to be stay focused. Experts say that how you direct your eyes and how you keep contact can be more important than what you say. The content, the matter may be having a minor impact, but the way you react may have a more impact. So that's why non-verbal communication becomes very important in an assertive communication. And be mindful of exactly what other person is trying to say. We need to listen. That is what is listening skill. Mindfulness means being present and not thinking about anyone else or who is not currently around you. And forget about the rest of the world. Look at the person who is communicating with you. Give your undue attention and listen whatever the person is trying to say. And always, you need to exercise how assertive you are by I messages. Not always. At the same time, if you are assertive, I message is very important so that you take responsibility for your own ideas and feeling instead of blaming the others, because ultimately you are the one who is making the decision. And there is always overlapping of things. Nothing is crystal clear. The needs of the leader and the needs of the other persons. And there is some common point that we are overlapping. So that point which when we need to listen, we can either be aggressive, we can either be passive. At that time, we need to be assertive, evaluating the situations. The assertiveness always comes in between. So we need to maintain a balance with our own as well as the others' needs. So as an administrator, we have our needs. What objective has to be met? What task has to be accomplished? At the same time, the others may say, okay, I want to leave at this particular time. I may want to leave. So how do we balance between both? We need to have a middle path that is taken. Assertiveness seeks the middle ground between passiveness as well as aggression. So we can either be too passive nor too aggressive. Somewhere in between the path has to be taken. Too passive allows the people to walk over you. You cannot be effective. It disrespects yourself. Too aggressive will have you working against the people. So it disrespects others. So better outcome happens when you work with the people. So we cannot be without other person. We cannot achieve anything alone. We need to have a good team. To have a good team, it is always better. Take the team with you. So be open, be honest, and be respectful. Strive for the assertive middle. And how you can become assertive? One is the softness that you speak. Avoid looking at people, showing little or no expression at all that as if whether you are interested or not, or slouches and withdrawing, which is very passive. If you're aggressive, you speak loud, you glare at them, you show intimidation reactions. So the in-between point is being assertive. Use conversational tones, make good eye contacts, and your expression should match your message. So what you talk and what you express should be matching. Relax and show open postures. How can we communicate in an assertive manner? The scenario 1 here says that clearly define and state your needs of expectations. So here, the leader says, we need to talk about a plan for our assignment today. What time works for you? So we are not insisting on a time. We are asking the other person's time of convenience. The second one, use I statement instead of statement. I need a better resources. So you are asking the person how he or she can cope up with the things. The third, practice saying no respectfully. I cannot do that for you right now. So maybe I may be doing later, but not now. The fourth scenario, practice speaking more professionally. I think I'll need to spend a full month preparing for this. That means you are saying how much time you require to deliver it effectively. So we need to see the I and you need to come together. Only then there can be an effective communication. There are some irrational beliefs arise when we are anxious about being assertive. Can we be assertive? Is it right? Will it be acceptable? Am I capable? So many uncertainties many times bother us. If I'm assertive, other people will be upset, hurt by it, or angry with me. If someone gets angry with me, I will be devastated because I want to please everybody. Assertive people are seen as cold and self-serving. It is wrong for me to turn down legitimate requests. These are all the feelings one can experience or undergo when trying to be assertive. Here there is a scenario. We can try this a second scenario instead of the first scenario, where we are saying, we are trying to make the child understand, the mother is trying to make the child understand that what difficulties she may have to face if the child is not owning the responsibility. So we are trying to take even the child who is not mature enough. So how important it is to take the adults along with us. That is important. The 6 techniques of assertive communication, just I would read out, already it has been explained. Behavior rehearsal, repeated assertions, fogging, negative inquiry. Negative assertions and workable compromise are very important to be having a assertive communication. What are the benefits of being assertive? Is it necessary? Is there any use? Yes. Gain self-confidence and self-esteem. Understand and recognize one's feelings. Earn respect from others because you stand firm for your conviction. Improve your communication. You can create a win-win situation most of the time. Improve your decision-making skills. Create honest relationships and gain more job satisfaction. And there are some other benefits also. You get a better communication. Less stress develops in your life instead of taking everything on one's own head. Gain more trust from others. You become more confident ultimately. And it creates a respectful environment where everyone grows and matures. Assertive communication lets you feel good about ourselves and others. We can pat our back. Yes, I handled the situation very good. I discussed with them and others also agreed. Wow, it's very good. So you also feel good about yourself. And nursing from the passive times, we are moving in the technology-driven world. So nursing must contend with its long history of subordination and identification with passivity. Everybody thinks nurses, yes, what they know. Just we tell, they will follow. Do we need a good nurse leader? No, anybody just with a minimum qualification could be appointed. This attitude of or the perception need to be changed. That is only by our assertive communication. So assertiveness can be one of the powerful tools to improve the image of nursing in society. So thank you for your patient hearing. Ma'am, can't hear.
Now you can hear now.
Yes, yes.
This
yes.
is what I like it. What Dr. Sudha said. Sometimes technology, we have to play and find out where it is.
Yes,
Thank you so much, Dr. Larissa, for presenting the important points in a nutshell. With a lot of examples for people to understand, like the 3 C's of communication, expressing positive and negative feelings, and most importantly, both the past speakers were talking about eye contact and communication. Just I was thinking that's all the more important now, because with this COVID and having the mask on, 90% communication is through eye only.
Yes.
So I think that's an assertive skill, and we should be able to communicate whatever we want through our eye contact. Thank you, Dr. Larissa. I move on to the third speaker. If the participants have any question, you can put it in the chat box, or I'll give you a time based on when Professor Prabha Dasila completes her session. I will introduce Dr. Prabha. She had her graduation from Devi Ahilya University, Indore, Madhya Pradesh, post-graduation from SNDT University, Mumbai, PhD nursing from Bharati Vidyapeeth University, Pune in 2011. She has a total of 36 years of experience in nursing, 29 years in teaching and 7 years in clinical. Has established 3 educational institutions in nursing for the MGM Trust, that is Mahatma Gandhi Mission Trust. She worked for 7 years at Kasturba Hospital, Bharat Heavy Electrical Limited, Bhopal, before entering into the education. After that, she moved to the MGM Trust as vice principal and moved up the career ladder as principal and professor in the later years. She also has more than 45 publications in various national and international journals, and is in the editorial boards of MGM Publications, and was a member of the editorial board of Critical Care Nurses Society of India. She is a member of about 4 professional organizations and a member of many of the top-level administration committees of MGM Group, and examiner in many other universities. Currently, Dr. Prabha is working as professor and director at MGM New Mumbai College of Nursing, and she is responsible for administration, research, teaching, and guiding of PG and PhD candidates. With this short introduction, I am very happy to welcome Dr. Prabha to talk to us on how assertive nurses are in their workplace. To you, Dr. Prabha.
Thank you very much, Dr. Anis George, madam. And actually, I want to tell I do not have any PowerPoint presentation. I will be just talking.
You're welcome. That is good.
Yes, ma'am. First of all, I appreciate Dr. Sudha Reddy, madam, for talking good words about her own teachers and mentors. It indicates, it shows how assertive those teachers were who looked after her and her batchmates and many more students who were under you, madam, and all other teachers. I also thank Dr. Asuma Bibi, madam, for inviting me for this panel discussion. Dr. Sijila for coordinating for this panel discussion, and the entire team at MIMS College of Nursing, Kerala for wonderful, for this wonderful conference. Thank you, madam, for asking the question, how assertive nurses are at their workplace. It is a well-known fact.
I already told her they will be waiting in Resamaja Road. Yeah, they are asked.
Someone has got the mic on. I request all the participants to mute your mic so that we can hear to the speaker. Thank you.
Yeah, it is well known that fact that any institution gets its recognition by the quality of care or education they provide. The hospital is recognized by the quality of care provided by the health team members. And in the health team, nurses play an important role. They work 24/7 in providing holistic care. They interact with different stakeholders as well as multidisciplinary team to tell them how is the patient's condition or about the treatment or any other matter for the care of the patient. Nurses also interact with patients with regard to various structured protocols. Example, if the patient has to go for any procedure or for OT, structured protocols are there. Those protocols are explained by the nurses to the patients. Sometimes they are also involved in the therapeutic counseling of the patient if they are not agreeing or if they have any difficulty.
ठीक हो ना प्रभा?
Yes, ma'am.
Take your time.
Just 1 minute.
No problem.
They also have social communication with the patient in an unplanned way when they advise to the patient for certain areas. They also interact with the patient's relatives and other members if there are any conflicts, resolution or anything. So they are involved in various type of communication when they are working in the hospital. When we are training the students, it starts from the home itself. We have to teach the students that all such scenarios will be seen in the hospital. Therefore, assertiveness is an essential professional criteria for the nurses. Here, they provide honest personal opinion, which is already explained by my previous panelists, that what is assertiveness and what are the different features of assertiveness. So the nurses are supposed to be providing positive and negative feelings without any fear. Actually, it is an art which can be learned over the year.
I am extremely sorry.
No problem. Take your time.
It is an art.
Okay, it's okay, Prabha. Take your time.
It is an art which can be learned over the year. Having assertive nurses at the workplace brings positive outcome. In the hospital, with regard to patient's outcome, and in the educational institution, the learner's outcome. Now, assertive nurses have good problem-solving ability. They are very confident, as it is already informed by the previous speakers. They are excellent in interpersonal collaborations. They have art of communication. They deal with very well with the patients, relatives, and other health team members. They make note of every point which can be communicated efficiently to others. And this is how they remain happy and satisfied, which enhances their job satisfaction. They enjoy their job and there is improvement in their performance. That is how their caring skill and their academic skills improves and their professional efficiency also improves. There are various researches indicated that our hospitals practice assertiveness. I have some researches which I will read out, that in one of the study in a private hospital in India, down south, about 76% of nurses had high level of assertiveness. They informed that they value their own experience and wisdom, and majority of them responded that they feel capable of learning new things. And they perform new tasks. They are comfortable with new people and social situations. They are able to say no without feeling guilty or anxious. So it is very nice to read to such articles. And there was another study also which indicated that 73% of nurses use assertiveness. But there are several studies which show that nurses lack assertiveness. They have limited assertiveness, and there are nurses unassertive. It could be because of the high-tech, fast-growing healthcare scenario, which demands qualified nurses who are technically sound, who are competent, who have good communication skills. Because now in the current scenario, because of the commercializations, patients are demanding and there is a feedback system, it helps improving the reputation of the hospital. Nowadays, if we go about, we see, we look at the reviews of particular institution, whether it is a hospital or any academic institution. There are stars. We'll look for whether 4 stars are there, where 5 stars are there, and what is the comment in the review before approaching to that particular institution. Everything available in the fingertip. So in such competitive world, assertiveness matters a lot. In the college, the teachers need to be assertive, which are inculcating these values to the students. Similarly, in the hospital, the nurses who are working from top to bottom, from the nursing superintendent to the staff nurse or the lowest grade nurse, everyone need to demonstrate assertiveness. It is learned from one to another. So from the top to the down line of organization, everyone teaches the other person and follows each one. Sometimes the nurses who are working in such hospitals or institutions, they find it difficult to have the assertiveness. Various factors are involved in this. The one is her own personal attribute. The attitude of that particular individual who is very casual in carrying out the responsibilities, the work which is assigned to her. Professional experience, she may not be experienced, or
if she has experienced, how was she handled by her senior, or what has she learned? Who was her role model? That also is demonstrated or is seen in the behavior of that particular individual. Sense of responsibility, if she doesn't take up the responsibility, and knowledge and competence. The changing healthcare scenario or the innovation in medical technology, the nurses also need to go on updating their knowledge and the skills. So we have to go on reading. Our teachers have told us, read, read, and read. That is how you go, you update your knowledge and your self-confidence. Number two is professional. How is the nurse trained? And how is she being trained when she is working somewhere? What is the hierarchical structure? Is she having any power of voicing herself? What is the team spirit? How is her team? What is her relationship with the team members of her own professional? Whether there are internal fights, how is her superior? What is the support of her superior? So this also matters a lot in presenting the assertiveness. Next, very important is the environment. In the current scenario, there is acute shortage of nurses everywhere. It is everyone's cry that there is shortage of nurse. So when there is shortage, there is increase in workload. Whether there are imposed powerlessness, whether she is not allowed to talk anything, or she's told, whatever I tell you, you do it. You are not allowed to give any of your opinion. Lack of well-structured policy. The institution does not have any good policies or any written policies which she can refer, and she knows what is to be done. Violence at the workplace, abuses, bullying by the physicians, the hospital, and the senior nurses. And sometimes she has no freedom to ventilate, no freedom to express. So these could also affect her practice assertiveness. This lack of assertiveness causes medical error. There may be poor interpersonal relationship. The nurse may have stress and burnout. She has job dissatisfaction and she drops out. There is resignations and again, further shortage of nurse. So we start assertiveness training from the time when a student joins the nursing college in the first year. Because it is an art, it can be learned. The student nurse, when she joins the first year, she follows her teachers, her mentors. So everyone at the college should be assertive. They have to practice what all the previous speakers have elaborated in their discussion. And so all the students can learn the art of assertiveness from the time they enter the institution. Apart from this, when they enter the institution, any hospital, the senior can provide feedback. Even in the college, the teacher can provide the feedback to the student. What are her strengths and what are her weaknesses, how she can develop the assertiveness. They can be trained accordingly, whether her attitude to be changed, whether knowledge and skills to be enhanced. Again, she can be observed, again, she can be trained, again, feedback can be given. So support the staff by having discussion, if there is any clash from the other health team members, the higher authority, the senior, the just senior nurse should be supporting by discussing, by having meeting or discussion with the health members of the other department. Enhancing working environment. Sometimes the nurse is not given adequate, good place to work. She doesn't have a resting room. She doesn't have place to sit and eat. So which gives her negative impact, which gives negative impact on her, and there may be clash and freedom, clash on her. So the senior person, the senior nurse who is her just supervisor should see that she is given a break in between and she is given a chance to express her feelings so that her stress and anxiety can be relieved. SOPs, protocols can be prepared so that nurses can refer those and they can work systematically in the area. And all these SOPs should be kept available so that that can be read and then they will be aware what is to be done next. Make stress-free environments as far as possible. So allow all the nurses to ventilate. So the superior who are available there from top to bottom, they should be role model. Definitely the nurses working under good empathetic leader will demonstrate assertiveness. That's all. Thank you very much.
Thank you, Dr. Prabha, for talking to us from your vast experience on the topic on how assertive are nurses in their workplace.
Sorry, madam, I had some disturbance in the beginning.
That is unexpected, unavoidable.
Yes,
we all as nurses attending this, we very well understand. Also, you have mentioned about, the various factors that can contribute for promoting and inhibiting assertiveness, like the personal, professional, and environmental factors. Most importantly, actually, when you concluded what you said, I really liked it, that the role of teachers in giving assertiveness training, not through just communication, but by being role models. Yes. Because I'm sure all of us who are teachers would have heard hundreds of times, not when our students were in our college, but once they graduate and go, then they come back and tell you that what they appreciated and what they have learned. So thank you to all the three speakers. I don't find any questions in the chat box, but if any of you who are participating would like to direct any question to any of the speakers, you are welcome now. You can unmute and talk. Dr. Asuma is telling no questions. Thank you. Nice to see. In all the forum, I tell that any conference, what I enjoy is the networking. But because of this COVID, the direct networking is not possible, but thanks to the technology, to which many of us are not very used to, but still, thanks to the technology for making it possible for us to see each other and to listen to each other. It was wonderful listening to these three young nurse executives who have spoken from their heart based on their experience. I hope everyone at MIMS and everywhere are all keeping fine. And from what we are hearing, that this corona, the third wave has slowly started its return journey. I hope it will speed up the return and then we will be free soon and so that we can have a normal life. I could attend only 2 or 3 sessions today. Dr. Wahida Rahman is still online. I want to tell you that a wonderful session on benchmarking and Dr. Savia on performance appraisal and management beautifully talked to. So I appreciate and congratulate once again Dr. Asuma and her team. Dr. Asuma supported by the Vice Principal, Dr. Shejila, and all of you for having interesting and very useful topics in this national conference. And I wish each one of you a very, very happy new year, and tomorrow's session a very fruitful session. Thank you so much. Thank you for giving me the opportunity to be with all of us. Thank you.
Okay. First of all, I have to thank Dr. Anis, my colleague, yesterday's colleagues and colleague and friend. Dear Anis, I know when I was thinking about assertiveness, you are the best person to moderate it. And I was telling Shejila, call Anis. Anis will talk. And Anis is one of the best assertive nurse I have seen, ever seen.
Oh my God, thank you so much.
I know, personally, I know Dr. Larissa and Dr. Prabha, and I have heard so much about Dr. Sudha Reddy too. And I thought people from middle age should come together to talk about assertiveness. That is why I was asking these three stalwarts to come and talk about assertiveness. I wanted to say thank you to all of you. I know Prabha was not feeling well. Still, she came and talked. And Larissa, thank you.
Thank you.
Dr. Sudha, thank you. Prabha, thank you.
Yes,
Thank you for
thank you.
your
Thank you, everyone.
Anis,
Thank you,
special
ma'am.
thanks.
Thank you, Anis ma'am, and panelists for the interesting discussion. With this, we have come to the end of today's sessions. Hope it was equally informative and understandable to all of you. And participants, please note, tomorrow our scientific sessions will start at 9 a.m. itself. So please be on time. And thank you and have a nice day.
Thank you,
everyone.
Shachana. Bye-bye, ma'am. Thank you so
Bye-bye.
much.
Thank you.